You will be given electronic sliding your
Direct होगा तुम्हारा
Press, no?
तो ऐसा लगा मुझे करना
and just keep storing someone will be there to assist you to use that.
Seven things. Nice.
Okay, friends. Good morning. Good morning. Please take your seats. Please take your seats. Before we actually start the function, I request college principal Dr. Axel Mangde Desai, program coordinator of the college, Dr. Swarna Potre, president of our group, Vadu Kamat, woman representative of our group, the Sikal Subrapurni, to come on the stage and light the candle. As in mountain aside to declare the event open.
Good morning, all. I declare open the Connect 2024 organized by the 1979 postdoc proud alumni of Goa College of Pharmacy. I wish every participant all the best. Thank you.
Thank you, Bharati. Before start of the forum, I would like to introduce our group 1979 Trustees Group of GCP. GCP stands for Goa College of Pharmacy. Actually, after passing in 1971, all our classmates never met each other. We were busy in our own run, mad rush to seek the job, to do whatever possible. It was only after 43 years we met for the first time under a banner Reunion One, and that day we took a vow to start a group dedicated to pharmacy college students. I will not elaborate much on our group. I will straight away take you to the introduction of our group. On the slide. Okay. Okay. For this function, we have appointed three judges. The two judges are our senior most uh, pharmacists passed out from our college of pharmacy. And the third judge is our classmate who was settled in Canada, and she has taken retirement just recently, and she came down from Canada to attend our function. So we were very delighted to appoint her as the judge for this event. Right? Uh, Now that we have almost welcomed the judges, uh, it becomes my duty to introduce the judges to you all.
few points. I want to as a chief judge for today's presentation conversation. So, without much uh, wasting any time further, I will start presentation with few tips to our students who are going to do the presentations. The presentation will start with the topic and accelerated intranasal rescue formulation for with prodrug and enzymes for severe emergencies. All participants of this subject will be called on the close to give their okay. So I request Ashok Pai to announce the first meeting and start.
Good morning, everybody. Good morning, everybody. Hello. The first contestant of the day is Ashleisha Matapatti. The next be ready is Vinit Bardwaj. And then third Shivraj Purkadli. Hello. Are you ready? Your time starts now.
Good morning, everyone. My name is Ashleisha Matapatti. The other day I was reading a study said 2.5 million people are diagnosed with epilepsy each year. WHO study also says that 50 million people suffer from epilepsy globally, making it a common yet a serious neurological disorder. The same WHO report said that 70% of people with epilepsy can become seizure-free if given the right treatment. And that is why the role of this intranasal extracted formulation with prodrugs and enzymes becomes vital. Let us begin with understanding what is a seizure. A seizure is a sign or symptom of having epilepsy. When there is excess of electrical impulses generated in the brain, it can manifest in the physical body in the form of twitching of muscles, jerking, or even stiffening, and sometimes becoming unconscious. It is basically caused by genetic factors, brain defect, experiencing physical trauma on the brain, and also having infections like meningitis. Epilepsy is a disease where a person experiences two or more unprovoked seizures. Let us look at the different types of seizures and the condition called status epilepticus. The different types of seizures are generalized seizures and focal seizures. As we can see, in generalized seizure, the electrical impulses are generated in both the hemispheres of the brain, while in focal seizures, the electrical impulses are specific to a certain part of the brain. Understanding this helps us in treating the patient. Stated epilepticus is a condition where seizures last for more than 5 minutes, while the average time for a seizure lasts is 2 minutes, making it a serious condition and an emergency situation to tackle. Wait, what are the different treatment options that we have? Benzodiazepines and barbiturates are the class of medications that we use, and they are incorporated in different dosage forms. These are some of the dosage forms that I've considered. First one is the dispersible tablets. It is administered through the oral route. The onset of this dosage form is 15 to 30 minutes. Next, we have the nasal spray. It is administered through the nasal route. The onset of action of this dosage form is 1 to 5 minutes. Then we have an infusion, which is administered through the intravenous route. The onset of action of this dosage form is also 1 to 5 minutes. Then we have suppositories, which are administered through the rectal route. The onset of action is 5 to 15 minutes. But wait, can we administer all of these dosage forms or any of these when a person is experiencing seizures? Not necessarily. Out of all these, nasal sprays, infusion, and suppositories show faster onset of action. But we cannot use infusion when a person is experiencing seizures because it can harm the patient. We cannot also use suppositories in case if the person is in a public setting. In that case, using a nasal spray becomes the best option. Now that we have understood the importance of this dosage form, let us understand why we use accelerated formulation in formulating this. Accelerated formulations are used to basically optimize and enhance the quality and efficacy of the formulation within less time, so that in that time we can make this formulation reach a larger or greater population. Prodrugs and enzymes. Prodrugs are the drugs which are pharmacologically inactive, but once they react with enzymes, they show their pharmacological action. As I said, benzodiazepines and barbiturates are used to treat epilepsy. The problem that they cause at the time of formulating them into a nasal spray is that they are not easily soluble. And that is where prodrugs and enzymes come to rescue. They are soluble and they also increase the bioavailability of the dosage. What are the advantages of incorporating prodrugs and enzymes into this nasal spray? Incorporating them into nasal spray will overcome the big problem of solubility. It will be easy to administer. No qualified personnel is required to administer this dosage form. It shows faster action, easy to administer to children, and more importantly, it is preferred in the public setting. There was a study published by the British Journal of Pharmacology in which healthy volunteers were given three different drugs through injections. One was diazepam, which is a traditional drug. The other one was abisopol, which is a prodrug of the drug diazepam. And the other drug that was given was a combination of abisopol, atropine, and palidoxin. The results that were obtained were the concentration of abisopol was higher than the concentration of diazepam after evaluating the concentration of different drugs. This is the reference of the previous study that we saw. There was another study published by the Journal of Pharmacology and Experimental Therapeutics in which abisopol was incorporated into drugs along with the enzyme human aminopeptidase. This drug also showed faster and quicker delivery and higher bioavailability. This is the reference of the previous study. Before I conclude, I'd like to encapsulate everything that we saw so far. Seizures are the signs or symptoms of having epilepsy. Status epilepticus is a condition, but seizures last for more than 5 minutes. Treatment options were the different dosage forms that we saw. The need for accelerated formulation that it will help us save time and optimizing and enhancing the efficacy of the product. Prodrugs and enzymes solve a major problem of solubility. Also, they increase the bioavailability. The main advantages of this dosage form is that they can be given since when they are experiencing seizures, they are preferred in a public setting. It is easy to administer to children. Also, no personnel is required to administer through this dosage form. Dr. Atul Gawande rightly says that the future of medicine is not about curing the disease, but about improving the quality of life. This is what your pharmacists stand for.
The next contestant, Vinit Bhardwaj.
Well, what I announcement, we will take the break in presentation competition sharp at 11:25 a.m. And then we go to live streaming of the talk on Generative from Boston, USA. Thank you.
Esteemed chief guests, respected faculty members, dear delegates, and fellow participants, a very good morning to one and all. Myself, Vinit Malukaj. The topic of the presentation is an accelerated intranasal rescue formulation with products and enzymes for seizure emergencies. Seizures are defined as a sudden uncontrolled burst of electrical activity that occurs in the brain. The exact cause of seizure is not known until now. So the first picture depicts the EEG pattern of normal EEG pattern. Second picture depicts the EEG pattern of patients suffering with partial seizure, and the third picture depicts the EEG pattern of patients suffering with generalized seizure. Generalized seizures are more dangerous when compared to the partial seizure. Next, coming to contents: introduction, what can cause seizure, advantages of intranasal route, medications for seizure emergency, recent advancements, limitations of intranasal route. Coming to introduction, seizure can be cause changes in behavior, movements, feelings, and level of consciousness. When a person has recurring seizure, they is defined as epilepsy. All epilepsy are seizures, but all seizures are not epilepsy. Coming to classification of seizures, there are mainly two types of seizures. One is focal seizure, one is generalized seizure. If seizures occurs at the frontal lobe, it is called as focal awareness seizures. If seizures occur at the median temporal lobe, it is called as focal awareness seizure. Coming to generalized seizure, there are different types of generalized seizure. Discuss about one by one. Coming to absent seizure, it is nothing but the patient starts staring into the sky without twitching of the muscle. Next, coming to the tonic seizure, it is nothing but the twitching of muscles that takes place. Next, coming to atonic seizure, it is nothing but loss of muscle tone which occurs due to twitching of the muscle. Next comes the myoclonic seizure. It is also caused due to twitching of the muscle, especially in the upper part of the body. Next comes the clonic seizure. It occurs due to twitches and rigors that takes place in the movement. Next coming to tonic-clonic seizure. As name only suggested, tonic-clonic seizure. Patients with tonic-clonic seizures have symptoms of both tonic as well as clonic seizures. Next coming to prevalence of seizures. About 1 in 10 people will experience at least one seizure during lifetime, but not always due to epilepsy. It affects approximately 1% of global population. In United States, about 3 million adults and 4,70,000 children have seizures. Coming to children, that is 0 to 14 years, cause of seizure is high fever, that is febrile seizure. Coming to adolescents, 15 to 24 years, cause of seizure is genetic factors, brain malformations, childhood brain injuries. Coming to adults, 25 to 60 years, cause of seizure is traumatic brain injuries, stroke, brain tumors. Coming to elderly people, 60 plus years, cause of seizure is age-related conditions like stroke, Alzheimer's disease, or brain tumors. Next, coming to triggers of seizure, high amount of stress can cause seizure, lack of sleep or sleep deprivation can cause seizure, due to exposure to high intensity of light for a longer period of time, seizure can be triggered, hormonal imbalance, that is especially oxytocin hormone, can trigger seizure, and longer exposure to TV and computer can trigger seizure. Next, coming to intranasal route of administration, it is a non-invasive delivery channel which allows treatment enter to CNS directly crossing BBB. There are three pathways through which drugs are targeted, mainly the olfactory nerve pathway, trigeminal nerve pathway, and blood circulation pathway. Mainly the drugs are targeted to blood circulation pathway so that they crosses the blood-brain barrier and reaches the CNS. The bioavailability of drug will be 100% when given through blood circulation pathway and convert the remaining to other pathways. Next, coming to advantages of intranasal route, hepatic first-pass metabolism is avoided, rapid drug absorption and quick onset of action, drug degradation observed in GVT, whereas in intranasal route it is absent. Large nasal mucosal surface area is available for drug absorption. It improves patient convenience and compliance. It directly delivers drug into systemic circulation and CNS. Coming to medications used for seizure, these are different types of medications that are used for different types of seizures, and the names that are depicted in the bracket are the brand names to which they are marketed. Next, coming to intranasal rescue medication for seizure. Nasal rescue medications are used especially in children or adults who are not able to take medicine by mouth or find this way of giving medicine more helpful. Seizures stop within minutes of giving nasal rescue medication and continue to work for much longer time. Intranasal rescue medications are absorbed quickly in the nose. As you can see in the picture, it is a device which is used to deliver the intranasal rescue medication. It mainly consists of three parts. One is cone, one is nozzle, one is holder. Cone is for protection, nozzle contains the drug, and holder is for support. With the help of nozzle, you can deliver drugs to the intranasal route. Next, coming to USFDA approved medications for seizure emergencies. Mainly there are two types of nasal sprays. One is Nasilone nasal spray and one is Valproco nasal spray. Midazolam nasal spray is brand name for nasal form of Nasilone. Starting dose usually prescribed as 5 mg. Second dose can be given 10 minutes or longer after first dose is prescribed. Coming to Valproco nasal spray. Valproco is the brand name for nasal form of diazepam. If starting dose prescribed as 5 mg or 10 mg, nasal spray is given as single spray into one nostril. If starting dose is prescribed as 15 mg to 7.5 mg nasal sprays are used. If starting dose is prescribed as 20 mg to 10 mg nasal sprays are used. Second dose can be given at least 4 hours after first dose is prescribed. Next, coming to enzymes used in seizure treatment. Superoxide dismutase, in short SOD, is an enzyme that scavenges free radicals, reducing oxidative stress, protecting neurons from damage during seizure episodes. Next, coming to catalase, is an enzyme that breaks down hydrogen peroxide, another form of oxidative stress, further mitigating harmful effects of seizures. Coming to glutamic synthetase, this enzyme regulates level of neurotransmitter glutamate, helping to restore balance between excitation and inhibition in the brain. Last one is transglutaminase. It can stabilize neuronal membranes, preventing uncontrolled spread of electrical activity that characterizes seizure episodes. Coming to recent advancements in seizure medications, they are used a drug called phenytoin, in vivo fluorescence imaging, and PTZ, nothing but pentylene tetrazote, induced acute seizure mode, demonstrated good brain targeted release and high therapeutic effect of bovine serum albumin loaded layered double hydroxide containing phenytoin after intranasal delivery. Coming to vigabatrin, present study developed a nano emulsion of vigabatrin that could deliver drug into brain through nasal route to avoid first pass metabolism and to avoid distribution of drug to non-targeted sites. Coming to parapanel, results suggested intranasal delivery through developed SMITs, that is self-micro-style drug delivery system, can be safe and promising alternative to oral treatment, which supports design of clinical trials to evaluate intranasal delivery to treat seizure and neurological related conditions such as anxiety. Coming to limitations of intranasal route, there is a risk of local side effect and irreversible diarrhea of cilia and nasal mucosa. Certain surfactants used as chemical enhancers may disrupt and even dissolve water in high concentration. There could be a mechanical loss of dosage form into other parts of respiratory tract like lungs because of improper technique of administration.
Please conclude.
These are the references that I wish for my presentation. So I would like to conclude my presentation. As such, the intranasal rescue medications are the best source for treating seizure emergencies. Thank you for giving me this wonderful opportunity.
Next contestant, Mr. Stewardship. Ms. Sumaya, please get ready. Stewardship, are you ready? Your time starts now.
Good morning, everybody. Myself Shiva. Coming to the topic, an accelerated intranasal response formulation with Warfarin and antibiotics. What are seizures? Seizures are the uncontrollable electron discharge in the brain, which may lead to the disturbance in the physical activity of the person. Types of seizures. There are two types of seizures: generalized seizures and focal seizures. Generalized seizures affect whole part of the body and lead to unconsciousness in the patient. And focal seizures, it affects only one part of the brain. And need for seizure treatment. There is a need for newer antibiotic drugs to be innovated with less side effects, and personalized medication should be formulated, and rapid emergency treatment should be done. And coming to the intranasal drug administration, intranasal drug administration are the drugs when the medication is passed through the nasal route, the absorption of the drug should be faster. Mechanism of action. When the let's take example of midazolam. When drug is administered to the intranasal route, it passes through the nasal mucous membrane and bypass first pass metabolism and enters into the systemic circulation and process blood brain barrier and binds to the GABA receptors. And further, it enables the GABA receptors and change in the effects of the neuron system take place and suppresses the neuronal activity take place and seizures are treated. And these are the two techniques for nasal seizures. Squeezing bottle, multi-dose, syringe, liver filter, unit doses form and continuous form. Advantages of intranasal formulation. Uh, uh, it helps to bypass first pass metabolism. They are easy to use, rapid onset of action, and prodrugs. Let's come to the prodrugs. Avizopam is used as a prodrug in diazepam. When avizopam is entered into the systemic circulation, it converts into the diazepam with the help of eoprotease enzymes. Prodrugs are used in several reasons. It improves the quality of water and enhances bioavailability, reduces toxicity, and enables specific site of nervous systems. Coming to the case study, done by rescue therapy for seizures, it was done in 2022. These are the formulations. Ethanol and methyl alcohol used as solvents, and PEG6 and methyl6 are used as the absorbent, and vitamin D helps for the increase in the absorption, increase in absorption of mucous membrane. And results, it shows that Intranasal shows that it has bioavailability of some 87% and diazepam has 97% through the nasal route. And they conclude that nasal route helps for nasal administration is better than the rectal administration for seizure treatment. And coming to the case study 2, a short review of intranasal administration for diazepam treatment. And in this study, oral route and IM and rectal and intranasal were done. And the onset of action for oral is 15 to 60 minutes and intranasal is less than 5 minutes. The biological oral route is 100% and rectal is 97%. And preclinical and clinical studies we have done in this study. They studied that diazepam is 10 mg and lonazepam with 4 mg. Cross-sectional study was used. And they found that they found that lonazepam in combination with diazepam were less effective for the seizure treatment. And reason for it is the current current drug used in the US FDA, and it is good for the treatment for seizure. And future aspects of the intranasal, improving the drug technology and improving the absorption and bioavailability, nanotechnology, and there should be development of nanotechnology and targeted drug health system. So I conclude that benzodiazepines are used for the nasal treatment for epilepsy. Further advancement should be done in the benzodiazepine.
Ms. Sumaya, and then followed by Mallika Rani.
Very good morning to everyone present here. My name is Sumaya, and my topic is accelerated intranasal rescue formulation with product and enzymes of seizure emergencies. Let us look at the objectives. Introduction to seizure and seizure emergencies, where I will be going to tell you what are seizures and when does a seizure becomes an emergency. Next, we'll see limitations of the current SQ medications that are available. Later, we'll see intranasal administration for rapid absorption and how intranasal possesses a big advantage over other routes. Next, we'll see utilization of prodrug and enzymes to make the nasal drug improvement. So, let us look at the seizures. What are seizures? Seizures are basically abnormal chemical discharge occurring in the neurons inside the brain. Okay, what happens when the seizure occurs? See, the seizure leads to improper movements and jerking movements inside the body. Seizures are basically classified into two types, that is generalized and partial. In partial seizures, only a particular part of the brain is affected, whereas in generalized seizure, the entire brain is affected. Now, since we know what seizure is, when does this seizure becomes an emergency? Okay, seizure becomes an emergency when it lasts for more than 5 minutes. Okay, during the onset of the seizure, the patient is unable to recover. Status epilepticus and acute repetitive seizures are two types of seizures that are considered to be a seizure emergency. What happens when these two seizures occur? These two seizures leads to prolonged seizure activity, can also cause hypoxia, metabolic acidosis, hypothermia, and other such risk of other diseases. Let us see what are the causes of seizures. There are basically two causes, medical conditions as well as external triggers for seizures. In medical conditions, we see epilepsy, stroke, brain tumors and infections are four main causes which leads to seizures. Other than that, there are some external triggers for seizures. Those external triggers are stress, sleep deprivation, substance abuse and flushing of lights. After we know what seizures are, let us look at the current rescue medications that are available to treat seizures. Benzodiazepines are the class of drugs that are used to treat seizures. In the benzodiazepine class, we have intravenous diazepam, intravenous lorazepam, or intramescaline midazolam. These are considered to be the first-line treatments for treating seizures. Apart from that, we have rectally administered diazepam, that is diazepam. Next, we have intranasal formulations as well as buccal formulations. The current medications that are used for seizure have some of the limitations. What are those limitations? Those are slow onset, variable bioavailability, administration challenges. Okay. Since we have seen seizure emergency can occur anywhere outside. So if you are present outside and you suffer from that seizure attack, intravenous drugs through syringes cannot be administered by doctors. We need such type of treatments that even common patients, even common human beings can give the patients. And the conventional current medications have slow rate of onset. And the other rectal route that is used, that can usually patients deny the rectal route because it is embarrassing for them. Now let us see what are the advantages of using intranasal administration. Intranasal administration of diazepam possesses a lot of advantages over other conventional routes. That is rapid onset, high bioavailability, and ease of use. The intranasal spray gives rapid onset of action, and also the route that is nasal route. Nasal mucosa is highly vascularized. That means the drug can easily go from nasal route to directly to the brain. And next is ease of use. Since it is in a spray form, it can be easily used and given to the patients. Even the intranasal route possesses some of the challenges. Those are poor aqueous solubility of the benzodiazepine class. And also they require certain co-solvents to prepare. Okay, the co-solvents are highly irritating in nature. They may cause irritation to the nasal mucosa. And also they have due to the utilization of solubilizing excipients, they have relatively slow time of action. So, to overcome these challenges, we utilize prodrugs and enzymes. What are prodrugs? See, basically prodrugs are inactive substances which, when administered to the body, release the active form of drug and shows its pharmacological action. The prodrug approach, that was the prodrug approach. Next is targeted conversion. The prodrug helps in directly targeting to the part where seizure has occurred and enhanced bioavailability shows combine to form a product. The product usually taken is abisafone. Okay. After the product is administered inside the body, the product with the enzymatic catalyzation causes the active drug to release into the body and show the pharmacological actions. For the product to work, we need enzymes. Enzymes help in they accelerate the process and also help in the enzymatic degradation of the product to convert it into the active form. The enzyme-based approach is used for the faster onset of action. They give target enzymatic activation, they rapid absorption, improved efficacy, and reduce side effects. Now let's take a research article wherein they have used mice and they have formulated the diazepam drug. They have formulated a research spray utilizing a diazepam drug along with enzymes asparagillus oryzes protease, and these products was administered to the mouse, and which showed that nasal route is highly appreciated because the plasma concentration is quickly reached if we use the nasal formulation. This is an example of how the product is converted into diazepam into its active form. So, in the conclusion, we see there are various routes present, but intranasal route possesses highly advantages over other routes. The utilization of product and enzymes accelerates the intranasal route and also causes viable. It is also a viable method.
Please conclude. Your time is up. Please conclude.
These are the references that I have used. Thank you.
Ms. Mallika Rani. Mr. Ritik, your presentation is next.
A very good morning to each one of you. My name is Malika Rani and I will be presenting the topic, an accelerated intranasal rescue formulation with prodrugs and enzymes for seizure medications. Imagine this situation. You're sitting in a cafe busy drinking coffee, when suddenly at the next table, a person falls on the ground and starts shaking uncontrollably. You hear someone whisper, "Oh, he's having a seizure." But what now? What do you do? How long do you wait until this seizure becomes an emergency? A seizure is a neurological condition marked by the occurrence of sudden and unpredictable interruption of neurons in the brain. There are primarily two types of seizure emergencies: acute repetitive seizures, and which are also known as seizure clusters, which are multiple seizures within 24 hours, where consciousness is regained in between, while it slowly progresses to a more serious form, which is known as status epilepticus, which leads to permanent brain damage, which lasts for longer than 5 minutes, or multiple seizures which occur without retaining consciousness in between. Normally, seizure medications work just fine, but what is the need for rescue therapy? It is to avoid seizures quickly and prevent the patient from going into emergency care. Out of all the available routes, the intranasal route stands out to be the most advantageous ones. This is due to a plethora of reasons. It includes the rich blood supply that is provided in the nasal cavity, the non-invasiveness which promotes patient compliance, and the rapid onset of action which is within seconds to minutes. The intranasal drugs are absorbed via two primary routes, that is through the respiratory epithelium directly into the systemic circulation, and also through the olfactory mucosa, which reaches the brain directly. Various formulation approaches have been adopted to improve intranasal delivery of drugs, which include involving the drug in low pH solutions, encapsulating the drug in cyclodextrins, which are cyclic sugar molecules, and using small particles such as microparticles and nanoparticles. Out of all this, the enzyme-mediated prodrug activation poses and shows a promising approach. The question arises that why do we not use the active drug directly? This is due to the limitations which are associated with using an active drug, which are the stability issues, the side effects of benzodiazepines, which are respiratory depression, and also excessive sedation. Prodrugs are pharmacologically inactive compounds that undergo metabolic conversion into the body to release the active drug. The whole purpose is to improve the solubility of poorly soluble drugs and also enhance targeted delivery. To understand this concept in a simple layman's term, let us take the example of this remote. You might think that this remote works right, but it does not. It lacks a key essential factor for its working, which is the battery. Consider the remote as the prodrug. The prodrug in the same concept requires the activation through the help of an enzyme, and the enzyme is the battery in this case. What is the role of enzymes in all this? Enzymes act as molecular seizures, which help convert the prodrug into an active form into the nasal cavity. And why just the nasal cavity? This is because the nasal cavity hosts a variety of optimum conditions of pH, temperature, and moisture. The types of enzymes that are used are esterases, proteases, and peptidases. Also, if enzymes are present in the nasal mucosa, what is the need for exogenous enzymes to be included in the formulation? This is because this helps the researchers control the rate and extent of prodrug conversion. This is an example of the enzyme used, which is aspergillus oryzae protease, which converts efimazole, which is a diazepam prodrug, into diazepam. Let us understand this concept through the help of a study which was done by the Department of Pharmaceutics and Clinical Pharmacology, University of Minnesota. The products used were water-soluble lysine prodrugs of diazepam and midazolam, and aspergillus enzyme protease was the enzyme. This utilized the cell culture model of MDCK, which is Madden-Darby canine kidney cells, which are used because they simulate the nasal epithelium. And a transfer system is used, which is divided into two components: the apical component, which represents the nasal cavity, the basal component, which represents the systemic circulation. Once the enzyme and the prodrug are administered in the apical chamber, it is absorbed rapidly through the basal chamber. The concentration of this is measured by using HPLC. Also, key strategy used is supersaturation, which enhances the absorption of the drug through the cell membrane. Analytical techniques such as high performance liquid chromatography, and to check the integrity of the cell membrane, we use microscopy, electron microscopy. This is the prodrugs which I use, which are diazepam and midazolam. Let us understand the results of this experiment through graphical interpretation. The first one shows the concentration of apical diazepam, concentration of active drugs versus time. Within the first 5 to 10 minutes, the drug is absorbed. The drug is rapidly converted by the enzymes into the active form. It reaches the peak concentration and decreases exponentially because the drug is transported across the cell membrane. Secondly, this is the concentration of the active drug in the basal membrane versus time. The concentration of drug in the basal membrane increases slowly because it shows a sustained absorption effect. For all its advantages, there are also challenges associated with this. The first challenge is that because we use Aspergillus oryzae, which is derived from fungal source, there is a risk of humans being allergic to the enzyme. So we need to find out a human compatible enzyme. Also, this study is done with only low doses of prodrugs. That is why we need to use higher prodrug concentrations for it to be clinically effective. And also, as we use an in vitro model, the nasal mucosa is having a high surface area. For that, we need to simulate the experiment in real-time conditions. And also, the concept of drug precipitation in the nasal cavity occurs, which can be prevented by the supersaturation strategy. These are the FDA-approved rescue therapies, which are sold under the brand names of Lystat, Nasalam, and Morpho. What does intranasal rescue formulation hold for in the future? We can try pharmacogenomics driven customization, wherein pharmacogenomic profiling of the drug can be done, and dose stage personalization. Also, Empatica which is epilepsy watch derived, can be used to monitor the seizures in real time and also notify the caregiver about the seizure which is occurring. Also, the utilization of nanoparticles can be done, which enhances the absorption, increases the targeted delivery. Finally, for all of its disadvantages, this poses to be a very advantageous route. Thank you.
Mr. Riddhi, time starts now.
Good morning, everyone. This is Ritik Revankar, and I'm here to present presentation on the topic an accelerated intranasal rescue formulation with products and enzymes for seizure emergency. To begin with, what are seizures? Seizures are electrical disturbances that are generated in the human mind, which will affect the bodily movement and the cognitive behavior. One thing what we have to remember is that seizure is not a disease but an associated symptom. Seizures are associated with diseases like cerebral palsy, alcohol withdrawal syndrome, Parkinson's, Alzheimer's, etc. Evolution of seizure treatment. To begin with, seizures primarily were managed with traditional medications like sodium valproate and phenytoin. Later on, we adopted the intranasal drug delivery due to its benefits with respect to bioavailability and rapid onset of action. Next, we adopted the strategy of prodrugs and enzymes because it was far more pharmacologically active as compared to the traditional approaches. Concept and methodologies for prodrug and enzyme incorporation. So to begin with, we are having prodrug design strategies. Now, what are prodrugs? Prodrugs are pharmacologically inactive components which when enters into the body and by means of chemical reactions will get converted into pharmacologically active components and will show the pharmacological effect. For example, we are having phosphenytoin and acetylcarboxylate. Next, enzyme immobilization techniques. Again, here there are two approaches. One, the enzyme can be used as a drug to prevent the seizure attack. Second, we can inhibit the enzymes involved in occurring of a seizure attack. Example, acetazolamide inhibit carbonic anhydrase. Next is combination therapy. That is by using prodrugs and enzymes technique together to give the synergistic effect. Significance of intranasal formulation in seizure treatment, we are having improved bioavailability, rapid onset of action, and reduced systemic side effect. In comparison with the traditional route of medication, that is the oral route, the intranasal route of drug delivery provides far more better bioavailability and also rapid onset of action because the drug is rapidly absorbed through the intranasal route. Next, it is reduced systemic side effect because the intranasal route of drug delivery is a localized route of drug delivery and does not consider the entire body component. Hence, any interferences from the GI and other disturbances are prevented and hence reduce systemic side effects. Recent advances in intranasal formulation technology, nanoformulation for enhanced drug delivery. We can adopt the nanoformulation to improve bioavailability or stability of the formulation and also to increase the pharmacological effect of the drug. Next, sustained release system. The seizure can last from 2 minutes to up to 20 minutes. Hence, sustained release systems are essential. Next, we are having smart drug delivery devices. The oncoming of a seizure attack cannot be predicted. Hence, amalgamation with a smart drug delivery device will enable to predict the oncoming of a seizure attack and will release the drug thereupon. Challenges in implementing prodrugs and enzymes. ensuring stability and activity of enzymes is very much essential. As products and enzymes are susceptible to thermal degradation, it is necessary to maintain their stability. Next, we are having optimizing product conversion rates, that is the rate at which the pharmacologically inactive product will get converted into the pharmacologically active form. That has to be calculated. Then, the navigating through the regulatory requirements, the regulatory agencies have a strict vigil on products and enzyme manufacturing. Hence, the manufacturer has to follow all the regulatory guidelines that are framed by the regulatory part. Strategies for overcoming implementation challenges, advanced formulation optimization, that is, we can adopt with nano formulation technology to improve the bioavailability and stability of the formulation. Next, preclinical and clinical validation. The manufacturer of the product and enzyme has to follow a standard clinical protocol along with the clinical validation approaches. A proper methodology is to be developed so that the results are trustworthy. Case study in product and enzyme-based seizure therapy. It was seen that Warfarin-loaded prodrug improved patient outcomes for focal seizures, lisdexamfetamine in the prodrug gave long-term benefits, and fosfenitoin gave personalized treatment approaches. Impact on healthcare industry and patient care, enhanced treatment options using prodrugs and enzymes are far more pharmacologically active components, and they are very efficient in treating the seizures in comparison with the traditional approaches. Hence, they are enhanced treatment options. Next, cost efficiency and resource utilization. The drug itself is sufficient in treatment of seizures. Hence, the chances of your hospitalization is reduced. Hence, it is cost efficient. Improve quality of life. The drug itself again is pharmacologically very competent and it will actively reduce the number of seizure attacks. Hence, it improves the quality of life. Ethical consideration in products and enzyme therapy. Informed consent in providing comprehensive information. Whenever an enzyme or a product is administered, it is vital to obtain the informed consent of the patient. Next, maintaining patient privacy confidentiality. Seizures are associated with social stigma, hence maintaining the privacy is of utmost importance. Next, addressing equity concerns in access to product and enzyme-based treatment. That is, every section of the society should be able to get the benefits of enzymes and products. Regulatory landscape for product and enzyme formulation, FDA approval process. The manufacturer has to follow all the FDA guidelines for proper regulation of the medication. The clinical trial requirement, the manufacturer has to develop a proper methodology for conducting the clinical trial. Also, the population has to be actively selected so that the results are trustworthy. Next, post-marketing surveillance. The manufacturer should have a methodology for post-marketing surveillance. In case if there are any areas, it should be actively communicated to the manufacturer. Future trends in product and enzyme research, precision medicine approaches. As I have said before, the seizure attack can last from 2 to 20 minutes, and precision medicine is very much essential. Biopharmaceutical innovation with respect to improving bioavailability and improving stability of the formulation. Pharmaceutically stable formulation, thereby improving their efficacy. Interdisciplinary collaboration, that is, scientists, doctors, pharmacists, statisticians should collaborate and develop such formulations which will improve the efficacy of the formulation. Conclusion, key takeaways, innovative intranasal formulations. Here we can adopt the nano formulation strategy also. Using AI tools, we can develop very much advanced formulation to improve the efficacy and bioavailability of the formulation. Challenges and opportunities which we have discussed before should be actively taken and overcome. Next, future directions. Future directions in the concept of product and enzymes can be with respect to improving bioavailability or by using nano formulation with AI-enabled and smart drug delivery systems. I will end my presentation with a quote: living with seizure means living with courage, learning that every setback is just a setback for a stronger comeback. Thank you.
Hello. There is a slight change in the presentation serial number, and the last person on the list will present first. That is Ms. Amisha Mandrekar will present antimicrobial stewardship and rational use of antibiotics. The next on the in line will be Ms. Shania De Silva. Then Jyoti then Akshata, then Naman, and the last presentation will be from Pratap. Your time starts now.
Fever, I'll take those antibiotics which is prescribed to you by the doctor, no? You'll be okay within 2 days. Still not recovered? I'll continue those antibiotics for 1 more month now. See, you might get well. Haven't we all have done this mistake before? Yes, of course not now, but there are many who still does that. A very good morning and a warm welcome to one and all present here. I'm Anisha Mandekar and I'm really grateful to be a part of today's program and to present on the topic antimicrobial stewardship and the rational use of antibiotics. So, in my today's presentation, I'll be covering the introduction to antibiotic stewardship, its goal, its challenges, its strategies, but also look into the ways how we can reduce it, some of the statistics, and yes, the future perspectives. So, before delving into the depth of the topic, let us understand the basics. So, the first thought that might have come up into everybody's head here is what is antimicrobial resistance? Isn't it? Yes. So, antimicrobial resistance is basically an ability of the microorganism that develops which prevents any antibiotic from working against it. And what are the consequences? Consequences like those of the ineffective treatment, high cost, and the worldwide spread is seen. Now, why I'm saying high cost? That is because when the patient stays in the hospital for a longer period of time because of the ineffective treatment, it is obvious that it is going to add to the medical costs. But then, how worldwide spread? See, let us take the basic cold and fever. The most common medicine that is prescribed during cold and fever is amoxicillin, right? So if any patient develops a resistance towards amoxicillin, and when that patient infects somebody else, maybe through the direct or the indirect contact, the resistance may get spread from one person to the other person. And when that other person touches somebody else, the resistance spreads from one person to the other person. We'll see how. So the next slide depicts the scenario of the global antibiotic market. So we are in the year 2024, right? Somewhere over here. So they say that by the time we reach in the year 2032, the rate of the use of the antibiotics, like those of the penicillin, cephalosporin, tetracycline, will almost increase by 2 to 5%. That is, we will move from somewhere around 43.8 to 58.4%, which is really very alarming. You know why? Because already in the year 2015, it is said that India was the largest consumer of antibiotics. Not only this, but according to the latest Lancet study, which is one of the famous journals, it is said that in India, the 60% of the death has been caused only and only because of the overuse of antibiotics. Is that good? No, not at all. So, which are those microbes that are getting resistance? The one that tops the list is Staphylococcus, which is almost the 25% of the followed by the Bacillus, that is covering up to 21%, followed by the other microorganisms. So, do you all think we can do anything about this? Is there any solution? Yes. And the solution is antimicrobial stewardship. Now, what is antimicrobial stewardship? Antimicrobial stewardship is basically an attempt made wherein we try to make the maximum use of antibiotics while having the lower risk to resistance, lower risk of side effects, and of course, the healthcare expenses. Every idea comes with a goal, right? So the goal here are first is to And lastly is to improve the health. Now, your thing are these, okay. So everybody faces some challenges, right? So AMS also has got some challenges. Now, which are those? Okay, it's India. So obviously, it's going to be lack of resource. Second, barriers in conducting those programs. Why? Again, because of the limited resources. Third is public misconception about it, which I have already told you before. Just like how we have got challenges, likewise, we also have got some strategies. And which are those strategies like we can implement an AMS committee. Second, we can create awareness and give education to the people. Third, developing stricter policies and stricter regulations. Now, are these the only method? No, right? I think we should start from the basics. Now, which are those basics? Basics like doing the right diagnosis, selecting the right drug, giving it for the right duration, and of course, reducing the empirical use. Now, what is empirical use? Empirical use is basically selecting the narrow spectrum antibiotics over a broader spectrum antibiotics. Besides that, what we can do from our side is we can meditate, we can exercise, we can eat healthy, we can say no to the drugs. And the most important part I would like to point out here is avoiding self-medication. Now, why am I saying avoid self-medication? That's because I've seen many people going to the pharmacist with the older prescription and saying, "Well, mujhe ye dawaii de do." You know, that will not work now because that's how the resistance has spread. And it is really very alarming. So we move on to the future perspectives. The future perspectives includes development of the new antibiotic, the spreading the awareness to media and education. There's a need to invest in new technologies and collaboration, global collaboration to combat the antimicrobial resistance. So, what we learn through this PPT is how the resistance is getting spread. What is the AMS program all about? Why does it need to spread the awareness? What we can do to combat the resistance, and why does it need to invest in new technologies? Last but not the least, they say think twice, seek advice, because antibiotics are not always the answer. Thank you.
Shadaya de Silva. Are you ready? Your time starts now.
Good morning, everyone. I'm Shania Silva, and I will be presenting the topic antimicrobial stewardship and the rational use of antibiotics. So now, what if I told you that humanity is making a collaborative effort to engineer the perfect superbug that could kill millions of us? Well, this is not just a futuristic nightmare. It is happening right now. We are creating a superbacterium that is resistant to all antibiotics. So now, what is this resistance? Let me tell you the story of a helpless mother who gave birth to two beautiful girls. Just moments after their birth, one of them is gravely ill. The doctors are trying everything they can, but nothing seems to be working. The mother holds her daughter in her arms and sings her a lullaby as her daughter falls asleep for the last time. This is the story of Christy, who died of sepsis in 2022. But why couldn't the doctor save Christy? The bacteria that infected Christy were resistant to all the antibiotics that could save her. The very drugs that were once considered miracle drugs were now powerless against this infection. is what is called as AMR or antimicrobial resistance. It is predicted that by 2050, every year, 10 millions of people will die of AMR. According to the World Health Organization, AMR occurs when bacteria, virus, fungi, and parasites no longer respond to antimicrobial resistance. As a result of this, antibiotics and other antimicrobial medicines become ineffective. Infections become difficult or impossible to treat, increasing the risk of disease spread, severe illness, disability, and even death. Now you may be wondering, I've never taken an antibiotic. How does this affect me? Well, you can acquire a superbug through a number of ways. Through poor infection control practices, through misuse in agriculture, through global trade and travel, and through the overuse of antibiotics. Now, for over 100 years, we've been playing a game of leapfrog. A drug and their resistance, another drug, and another resistance again. Now, this game is ending. So what's the worry? Big Pharma is going to come and save us all, right? Well, it's not that simple. We find ourselves at a crossroads. We cannot develop new antibiotics fast enough to keep up with the evolution of bacteria. So, we have to forge a new pathway. And that pathway is that of antimicrobial stewardship, or AMS. In the most simplest terms, antimicrobial stewardship can be defined as when a patient gets the correct drug for the specific infection via the most appropriate dose and route of administration for a very specific duration and still be very effective. Now, there are two approaches in antimicrobial stewardship. That is the front end or the pre-prescription approach and the back end or the post-prescription approach. So now the front end or the pre-prescription approach is like a traffic signal for a traffic jam, where the red light allows only certain cars to pass through. So in this case, doctors, without special approval, must wait before using specific antibiotics. This approach uses restrictive prescriptive authority because certain antimicrobials are considered restricted and require prior authorization. Now the back-end approach is like a GPS system. You get your journey, but the journey keeps getting updated based on new routes. So now an antimicrobial steward reviews a prescription and recommends changes based on patient's response and lab results. So now this approach is based on review and feedback, wherein the antimicrobial stewards provide clinicians with recommendations either to continue, change, adjust, or discontinue therapy. So now let us understand the biggest picture. What is exactly the rational use of antibiotics? It ensures that antibiotics are only used when they are truly needed, preventing their overuse and the risk of resistance. It also ensures patients receive optimal treatment with fewer side effects and better outcomes. And you may be wondering, this is the same as stewardship. Well, both of them go hand in hand. While antimicrobial stewardship provides a framework, the rational use means applying these principles at your bedside. So now there are a few strategies for antimicrobial resistance, which include formulary restriction that restrict certain antibiotics, order sets and treatment algorithms, where you have step-by-step plans for treatment choices. And we have clinical guidelines, education and awareness, pharmacodynamic dose optimization. All these strategies are used to ensure proper antimicrobial stewardship. So now, how can each one of us be an antimicrobial steward? As a consumer, you go to the doctor, you feel a cold coming on, you say, "Doctor, I feel sick, give me some antibiotics." This is without stewardship. But with stewardship, you tell your doctor, "I feel sick, these are my symptoms, what do you recommend?" Because you see, I am concerned about the overuse of antibiotics and the risk of acquiring Seizure or a superbug, because I am an antimicrobial steward. Or maybe you are a patient and you go to the hospital. Without stewardship, you just let your medical team examine you. But with stewardship, you ask them, "Have you washed your hands before you touch me?" Because you see, I am concerned about the risk of acquiring C. diff or a superbug in your hospital, because I am an antimicrobial steward. Or maybe you're at a restaurant and you order your favorite steak. Without stewardship, you just eat it. But with stewardship, you'll ask the waiter, "Is the meat you serve here antimicrobial free?" Because you see, I'm afraid of the overuse of antibiotics in animals, and I'm afraid of the risk of acquiring C. diff. and a superbug because I am an antimicrobial steward. So remember, there is another and a more severe pandemic at our doorsteps, and it is our responsibility to protect ourselves as well as our loved ones. I am ready. Are you? Thank you.
Miss Jyoti. Miss Jyoti, are you ready?
Yes, sir.
Your time starts now.
Good morning, all. I am Jyoti Tangiri. Today I am going to present antimicrobial stewardship and rational use of antibiotics. Let's start the presentation. Antimicrobial stewardship is an essential aspect ensuring the effective and appropriate use of antibiotics. It's about using this medication to minimize the resistance of antibiotics. Now, what is antimicrobial resistance? Antimicrobial resistance is a growing factor where the bacteria, fungi, virus, and other parasites become resistant to the antibiotics. Antibiotics are the drugs which are prepared by using the bacteria. It's because of increased use, improper dosage, and inappropriate use. Now, there are some key principles which guide us to responsible use of antibiotics, like prevention, diagnosis, prescription, duration, monitoring, and education. Prevention: reduce the need of antibiotic by taking some major control and giving the more importance to the prevention of antibiotic by giving the awareness. Accurate diagnosis is must by avoiding the unnecessary prescription of antibiotics, and in the prescription, prescribe the drug based on the type of infection, patient susceptibility, allergies, and local resistance pattern, and duration should be appropriate to prevent the unnecessary prolongation of treatment. Monitoring with the patient will help us to give effective and adjust the treatment if it is necessary, and education to the patient which help us to guide the resistance mechanism and responsible use of drugs. Now, the importance of stewardship is optimized use of drug. So it can be done by giving effective treatment, reduced cost, and preserving the antibiotics. See, these are the intercorrelated with each other. First, the stewardship makes sure that patient should get effective treatment. If he is getting the effective treatment, then there is a reduction in the cost by preventing the unnecessary prescription. If the patient is getting effective treatment, reduced cost, then there is a preservation of antibiotic for the future generation. Next, the strategies we can apply like provide some evidence guidelines for the selection of drug dose and duration of therapy. Antimicrobial cycling is nothing but rotating of antibiotics, or you can change the drug. If the patient is coming first time, then you prescribe A drug, and if he comes, then prescribe the drug instead of B. And therapeutic drug monitoring, which help us to appropriate and prevent the adverse drug reaction of the antibiotics. Now, we can do some implements like create some policies before prescribing the drug, give ongoing training for the healthcare professional regarding the stewardship program by next use technologies for preserve the patient optimal dosage and duration. First, you have to correctly identify what is the cause of infection and select the drug based on the type of infection, severity, and optimal dosage and duration, which helps to get effective treatment with minimum resistance of drug. Now, the common misuse, overprescription, self-medication, and incomplete course. See, if you prescribe the antibiotic for the viral infection, which is not going to treat, because viruses which enter the body from the outside. Second, self-medication. Nowadays, people what they will do, they will take the medication by referring the previous prescription. If they do such a thing, the drugs are already registered in the body, which is not going to treat. Third, incomplete course. The people will stop the treatment early and they will again start the treatment. If they do such kind of things, the drugs are already registered in the body. Next, the benefits. Gentle use of antibiotics leads 40% in the resistance, which leads to the preservation of antibiotics. 30% will get the economical benefits by reducing the cost by prescribing the unnecessary drugs, and 20% healthcare quality by giving the best treatment in shorter period of time. Next, the guidelines for use. We can apply some guidelines for prescribing practice, dosage and duration, patient education, monitor and de-escalation. Next, the patient engagement and involvement is must. First, understand the risk. The patient should understand what will happen if they overuse the medication. Ask the question. Encourage the patient about. They should ask the question about the healthcare professional that why they are taking the drugs, and complete course because they will stop the therapy in shorter duration and avoid the sharing of antibiotics, which is very harmful. Next, the role of healthcare professionals. Doctor, nurse, and pharmacist who plays very important role. Doctors by prescribing the antibiotic. Nurses by educating the patients regarding the ADR, and pharmacists giving the education to the healthcare professional regarding the resistance of the mechanisms. Then these are the some recent publications which published, and it is a case study which is conducted in the year of 2023. They concluded that they successfully implemented the stewardship program by collaborating with the hospitals, and which is urgently needed in the India. And these all are the references I use. Thank you.
Miss Akshata, then Naman, and then Pratham. Akshata, are you ready? Your time starts now.
Good morning, everyone. My name is Akshata P. Hepburn, and the topic that I am here to present is antimicrobial stewardship and the rational use of antibiotics. To begin with, the concept of antimicrobial stewardship, it began with two intentions. The first one, to give appropriate therapy as per the individual's need, and the second one is to give a sustained access for a long-term and effective therapy. However, this antimicrobial stewardship was referred explicitly in different descriptions. It was described as a program, a set of interventions, as an approach, a method, a means to tackle, and etc. So, is AMS required? Is it needed? Yes. Why is it needed? So, according to a Japanese company, it's a healthcare company, they have estimated that by 2050 there are going to be around 10 million deaths, and these are some of the expected number of deaths
on the globe. Now, what are the causes for this antimicrobial resistance? Some of them are overuse and misuse of antibiotics, patient non-compliance, lack of awareness among the people, and antibiotics used in the livestock farming. Now, what strategies can be implemented to use these antibiotics rationally? They can be like such as prescribing guidelines and protocols, educating and training the people, not just the people, but the students, the pharmacists, and all healthcare professionals, monitoring and feedback, giving infection control practices, and above all, public health interventions. Well, one such example for the rational antibiotic use is AWARE, that is launched by the WHO. Well, this AWARE is divided into three concepts. The A stands for the axis group, wherein the first and the second line, or the first or the second generation antibiotics are used. They give the best therapeutic value and with minimized potential for resistance. The second group is the watch group, where the same first and second generation antibiotics are used. They are again specific, limited, and they are more prone to AMRs. The last group is the reserve group, which has to be closely monitored, and they are the main targets of antimicrobial stewardship. Now, what can a physician do? He or she can assess this list by prescribing the antibiotics. Now, based on this assessment list, the principles of AMS are as follows: optimizing antibiotic use, de-escalating and narrowing therapy, diagnostic tools, multidisciplinary approach, prevention of unnecessary antibiotic use, and monitoring the adverse effects. Now, some of the core elements of antimicrobial stewardships are accountability, leadership commitment, action, tracking, education, drug expertise, reporting, and optimizing the prescription of antimicrobials. Now, where all can we implement this? Where all can we implement this? It can be implemented in hospitals, nursing homes, outpatient clinics, and the places where the resources are too less. Interventions. The most important interventions before or at the time of prescription is delabeling of spurious antibiotics, prior authorization of restricted antimicrobials, cumulative antibiograms, clinical education, prospective audit. These are some of the interventions that should be taken after the prescription. These are prospective audit and feedback, antibiotic timeouts, antibiotic dose optimization, and antibiotic duration. So, what impacts and benefits can be obtained by this stewardship? Well, there could be an improved treatment, reduced resistance rates, reduced drug adverse events, and fewer complications associated towards the hospitals and enhanced patient safety. Now, let's see a case study. So, from the year 2011 to 16, a retrospective observational studies was carried out in a tertiary hospital in China, and the interventions that they took was activity program, launching it, performing and managing it, and training all the healthcare professionals. And the outcomes measured were antibiotic prescriptions, intensity of consumptions, antibiotic prophylaxis, and resistance rate. And what impact was observed was that there was a less resistance rate, less prophylaxis, and the prescriptions which were given to the outpatients as well as the inpatients were reduced. So, who all can participate or in this AMS? Well, all of us. Being it from a physician, a pharmacist, a patient, or a nurse, everyone plays a vital role in carrying out this and implementing this antimicrobial stewardship. Now, these are some of the challenges such as lack of time availability, leadership commitment, poor financial support or the laboratory support, and what solutions can be given to them. Integrating AMS into regular workflows so that the lack of time is resolved,
And most important of all is implementing One Health stewardship. This is something which many people are unaware about. Well, it is a multidisciplinary approach where it mainly aims to improve the healthcare outcomes by collaborating animals, humans, and the environment. To conclude, AMR is something, it is a global threat, and the solution for this would be AMS. And by working together, we all can combat AMR and we can ensure a healthier future. So antibiotics can save lives, but stewardship will protect them to tomorrow. These are the articles which I have referred to, and thank you.
Mr. Naman Kothari. Mr. Pratham, you get ready, please. Are you ready?
Yes, sir.
Your time starts now.
A very good morning to one and all present here and those present virtually. Esteemed judges, respected faculty members, other delegates, and my fellow participants. I, Naman Kothari, with bringing excitement, would like to present my presentation on the topic antimicrobial stewardship and rational use of antimicrobials. I'd like to begin by saying something. WHO has already declared antimicrobial resistance among the top 10 global public health threats. So isn't it really concerning for all of us? It is right. We are on the verge of a post-antibiotic era where bacterial infection could once again kill all of us because we have standardized the use of antibiotics through misuse. So let's deep dive into my presentation today and try to find out answers to all the questions. I hope to leave you with a better understanding of the topic. Let's get started. Agenda and flow of my presentation is as follows. First, we will see introduction to antimicrobial stewardship. Why antimicrobial stewardship? AMR, that is antimicrobial resistance and its various mechanisms. Global impact of AMR. Strategies for antimicrobial stewardship. Evaluation of antimicrobial stewardship programs. Rational use of antibiotics. Some case studies, real life case studies examples. Challenges and barriers that have to be overcome in implementation of antimicrobial stewardship programs, and some future directions and innovations. Introduction. What actually is antimicrobial stewardship? Antimicrobial stewardship is a coordinated effort to promote the appropriate use of antimicrobials in order to combat antimicrobial resistance. It emphasizes on giving the right drug to the right patient at the right time and for the right duration of time. Rational use of antibiotics is crucial and essential in preserving the antibiotics for future use and to reduce the harmful potential side effects caused by the inappropriate use of antibiotics. Have you ever wondered why in this room are we even talking about antimicrobial stewardship? Like what has led us to this moment? The villain for our today's presentation is antimicrobial resistance. What exactly is antimicrobial resistance? Antimicrobial resistance is the ability of microbe to develop resistance against antimicrobial drugs, rendering them ineffective. Impact antimicrobial resistance will lead to increased morbidity and mortality rates, prolong hospital stays, and will drive up the healthcare cost eventually. Causes over and misuse of antibiotics, poor infection and control practices, superbugs, lack of access to effective diagnostics are key contributors. I'd like to mention an example of livestock animals that are maintained under very unhygienic conditions and routinely administer antibiotics to prevent infection in them. So this, due to routinely administration of antibiotics, this superbugs are developed in them, and when the infections are spread from those animals to humans, these antimicrobial drugs are ineffective for the treatment in humans. This was one example of how antimicrobial resistance is developed. Coming to mechanism of antimicrobial resistance, how does a microbe develop resistance against antimicrobial drugs? These are the mechanisms through which inactivation of antimicrobials. In this scenario, the microbe develops some enzymes that convert the drug into inactive substances which are ineffective. alter target sites so that the drug does not bind to the receptors effectively, reduce drug uptake, and increase drug efflux by active transportation. Now that we have understood antimicrobial resistance is a problem, how big it is as a problem? I was anguished by seeing this stat that antimicrobial resistance contributes to 12,70,000 deaths per year, which is even bigger than road traffic accident rates, which amounts to 12 lakh deaths per year. And if antimicrobial stewardship programs are not implemented right now, by the year 2015, antimicrobial resistance would be as big as cancer. So implementation of antimicrobial stewardship programs is the need of the hour. Let us look at our case study of how antimicrobial resistance has affected India. More than 70% of E. coli strains isolated from urinary tract infection patients were resistant to fluoroquinolones in certain parts of India. The contributing factor for the same were over-the-counter antibiotic sales, inappropriate prescribing practices, substandard and counterfeit drugs, poor infection control and sanitation. There are plethora of strategies that have to be implemented for antimicrobial stewardship programs. First one being education and training for physicians and healthcare professionals. Second one, guideline development by government. Antibiotic review and feedback. Formulary restrictions for broad spectrum antibiotics. Infection prevention and control, where we can, in the first phase, we can control infection so that there is no need of antimicrobials. Rapid diagnostic testing, optimization of therapy, multidisciplinary teams will have to join hands and work together. Monitoring, continuous monitoring and surveillance is another strategy that has to be implemented for antimicrobial stewardship programs. Coming to monitoring and evaluation of a stewardship program, this also plays a crucial role to monitor and evaluate a stewardship program. There are three parameters on which we can monitor and evaluate a stewardship program. First one is the baseline data that acts as a starting point where we observe the antimicrobial use patterns and resistance development patterns and set up a starting point. Process indicators track the implementation of a stewardship intervention and assess the impact on antimicrobial use. For example, like if we implement educating our professionals, how is educating our professional impacting on the impact of antimicrobial use? Has it reduced the resistance rate? This is the second indicator, that is process indicator. Outcome indicator, evaluate the effectiveness of stewardship programs by monitoring changes in resistance rates, clinical outcomes, and healthcare costs. So this is the overall evaluation of a stewardship program. Let's look at some successful story in antimicrobial stewardship program. Sydney's Children's Hospital Network implemented an EMS program to reduce inappropriate antibiotic prescription for pediatric patients. Interventions where they emphasized on guideline development, regular audits, and parental education to avoid misconceptions. The outcome was really impressive as the program led to 30% reduction in antibiotic prescription for upper respiratory tract infections. The use of broad spectrum antibiotics was replaced with narrow spectrum antibiotics and improved awareness of appropriate prescribing practices leading to better patient. So this is a great takeaway for all of us to as a success story in antimicrobial stewardship. A role of multidisciplinary teams in antimicrobial stewardship. Antimicrobial stewardship is not a single professional responsibility. All these professionals will have to come together for the implementation of stewardship programs, from physicians who prescribe antibiotics, nurses who administer and monitor the patients for side effects, pharmacists who review this prescription and provide guidance to the patient, microbiologists who will identify pathogens and perform susceptibility testing and provide guidance on antimicrobial selection, infection control specialists who will monitor this whole program of antimicrobial stewardship. There are some challenges and barriers that we might face in the implementation of this. First one being lack of resources, inadequate training, patient expectations, availability of antibiotics, future directions in antimicrobial stewardship is not just a medical responsibility but a societal one. By addressing the root cause such as overprescription, lack of awareness, and insufficient innovation in antibiotics, we can mitigate. Solutions like education. Misusing antibiotics is like using a fire extinguisher on a candle. very unnecessary and dangerous when the real need appears. Misuse of antibiotics does not affect one patient, but it endanger the future of medicine for every one of us. Let's ask ourselves one question today. As responsible individuals and professionals, are we doing enough to ensure that that our actions today will lead to long-term sustainability of antibiotics in the future? I would like to end my presentation by saying that antimicrobial stewardship is everyone's responsibility, from healthcare professionals to all the way down to patient. We must all join hands and work together to safeguard the future of antibiotic. Thank you. Thank you once again.
Mr. Pratham. Mr. Pratham, are you ready?
Yes, sir.
Your time starts now.
A very warm good morning to you all. My name is Pratham Pasulkar. Very happy to be part of Connect 2K24, nestled in the picturesque environs of Goa. Today, I'm here to present a seminar on a topic which has paramount importance on our healthcare system: antimicrobial stewardship and rational use of antibiotics. Before we move on to the topic antimicrobial stewardship, let us know about antimicrobial. Antimicrobial include antibiotics, antiviral, antifungal, and antiparasitics. So these are the medicines used to prevent and treat infectious diseases in humans, plants, and animals. From this, there arises a concept antimicrobial resistance. When bacteria, fungi, viruses, and parasites will no longer respond to antimicrobial resistance, antimicrobial medicines. As a result of this drug resistance, antimicrobials and other antibiotic medicines becomes ineffective and it's difficult to treat infections. As antimicrobial resistance was growing across the globe, two internists, John Liam Gowen and Dale Kennedy, coined the term antimicrobial stewardship in the year 1996 at Emory University of Medical Science. Antimicrobial stewardship is a coordinated program that promotes about the appropriate use of antimicrobial. If there is appropriate use of antimicrobial, then there will be reduced in antimicrobial resistance. If antimicrobial resistance is reduced, then there will be decrease in the spread of infection. If there is decrease in the spread of infections, there will be improvement in the patient outcome. What was the need of antimicrobial stewardship? According to my dear friends, antimicrobial resistance is one of the serious challenges we are facing globally. According to the World Health Organization, in 2019, there were 1.27 million global deaths just because of the bacterial antimicrobial resistance, and overall, there were 4.95 million deaths. The World Bank estimated that there would be $1 trillion additional healthcare cost by 2050, and there will be GDP loss of about $3 trillion every year due to significant increased healthcare costs. Antimicrobial stewardship has wide advantage in our medical science, from prescribing antibiotics to discover antibiotics, from controlling the infection to educating our staffs. Today, our goal is to delve into the principles of antimicrobial stewardship and explore the various programs by World Health Organization to control antimicrobial resistance. Principle of antimicrobial stewardship can be explained using 5D concept. The first P stands for disease. Here, you need to see whether the disease is bacterial or viral. In case of pneumonia, there are two types: viral pneumonia as well as bacterial pneumonia. You cannot prescribe antibiotics for viral pneumonia. Next one is drug. You all know you need to see whether the bacteria is susceptible to which or not. For example, if any patient comes to you with pneumonia, let us assume it is a community-acquired pneumonia. Then the most disease-causing organism is Streptococcus pneumonia. Then you would suggest that ceftriaxone but not meropenem, because Streptococcus pneumonia is more susceptible to ceftriaxone. Next one is dose. So here, to treat the disease, doctor prescribes recommended dose. For example, ciprofloxacin can be recommended 500 mg twice a day. Next one is duration. As we all know, doctor prescribes antibiotics only for a certain period of time. In case of pyelonephritis, doctor prescribes antibiotics for 14 days. In case of pneumonia, doctor prescribes antibiotics for 5 to 7 days. Sometimes he may extend to 10, but not more than that, because then there arises a problem, so-called antimicrobial resistance. And next one is de-escalation. So there are certain drugs which has good oral bioavailability. If a patient is given IV ciprofloxacin, then you can give it orally ciprofloxacin as it has a good oral bioavailability. Now let us look after various programs by World Health Organization to control AMR in countries. The first one is AMR National Action Plan. To ensure the sustained progress, establishment of multi-sectoral AMR governance mechanism which will prioritize activity and develop a cost-effective plans. Next one is the people-centered approach and WHO 4 package of interventions. So to address AMI in a programmatic manner, to address the need of the people to have equitable access to health services. Next one is antimicrobial stewardship and awareness. To educate and support our healthcare professionals to follow evidence-based guidelines on antimicrobial resistance. And last is strategic information to inform the AMR response. WHO launched GLASS, Global Antimicrobial Resistance and Use Surveillance System, in year 2015 to fill knowledge gaps and inform strategies. Now, we look after WHO programs to control AMR in countries. The first one is AMR National Action Plan. So to have and sustain progress, establishment of a multi-sector. Next one is global action on antimicrobial resistance. First one is One Health approach. So to achieve optimal and sustainable health outcomes for people, animal, and ecosystem. Next one is global action plan. So several countries adopted the global action plan on AMR to develop and implement multi-sectoral national action plans. Next one is various organizations like World Health Organization, Food and Agriculture Organization, Human Environment Protection, as well as World Organization of Animal Health, established to supported the establishment of Global Leaders Group on AMR, which started the work in November 2020. Next one is there will be recent high-level ministerial conference which will be hosted by Kingdom of Saudi Arabia in 2024. And the last one is World AMR Awareness Week. It is one of the World WHO officially campaign started in 2015, celebrated every year from 18th November to 24th November. Now, we look after the rational use of antibiotics. The rational use of antibiotic implies that there should be appropriate choice of an antibiotic administered at the correct dose, with correct frequency, with correct duration, and with the appropriate route of administration. To reduce the effect of antimicrobial resistance and preserve antibiotic effectiveness, the clinical practice guidelines and health policy documents, which call for key components for very responsive to AMR that aims to avoid unnecessary or minimally effective antibiotic prescriptions. Here, there are certain AMR drugs and the side effects, along with some antibiotics, antiprotozoal, antifungal, and the next one is about some recent irrational use of antibiotics are flucloxacin, cephaloxone, cefalozone, and ceftriaxone. During COVID-19, there was a misinformation that azithromycin used to cure COVID-19, but that was totally a false. There was inappropriate use of antibiotic azithromycin. And last one is optimizing use of antibiotics and discovery of novel antibiotics are critically important to protect patients from cancer, in cancer patients from antibiotic resistance infections in the future, because antibiotic resistance threatens the progress against cancer. Thank you everyone for being part of Collective K24. Let us champion these principles in our professional practice. Thank you.
Our next topic is how pharmacogenomics can be used to personalize medication with examples. We are going to ask the participants at random, not in line. So Ms. Bhagesri will be the first to present, then Archana, the next will be Sheetal, then Nisarga, then Simran, and Kirti. So I repeat, the first one will be Bhagesri, then Sheetal, then Archana, then Nisarga, and Simran and Kirti.
Very good morning to one and all. Myself Bhagyashree Shivani, and I am here to present.
Are you ready?
Yes.
Your time starts now.
Good morning, one and all. Myself Bhagyashree Shivani, and I am here to present on a topic entitled How Pharmacogenomics Can Be Used to Personalize the Medications with Examples. Pharmacogenomics is a field that explores how genetic variations influence drug response. It's relatively a new but rapidly evolving field that aims to personalize the medications based on the individual genetic profile. How did the pharmacogenomics evolve? The history of the pharmacogenomics stretches as far as 510 BC, when Pythagoras noted that ingestion of pharma beans resulted in a potentially fatal reaction in some, but not all individuals. Later, it was discovered to be due to the deficiency of the G6 gene. In 1866, Mendel established the rules for heredity. Following on 1957, Frederick Vogel coined the term pharmacogenetics. On 1962, Callow published an article, Pharmacogenomics, Heredity and the Response to the Drugs. And on 2000, completion of the first draft of the human genome was told. Next is how pharmacogenomics works. Pharmacogenomics works by predicting the drug response, preventing the adverse drug reactions, enabling the drug discovery and development, developing targeted drugs for cancer therapy, and predicting the activation of the prodrugs, improving efficacy. How pharmacogenomics can be used to cure the incurable diseases. Imagine a world where the diseases like diabetes, HIV, AIDS, cancer, and neurodegenerative diseases are no longer considered to be incurable. The pharmacogenomics works by optimizing the insulin therapy in the diabetes and optimizing antiretroviral therapy in the HIV or AIDS and targeted cancer therapies in the cancer disease and predicting drug response in the neurodegenerative diseases. Turning impossible into reality for the diseases that were once considered incurable opens new pathways by targeting genetic triggers of the diseases. Next is understanding the genetic variations. There are different types of the genetic variations which are need to be considered. They are genetic polymorphisms, common number variations, single nucleotide polymorphisms, and pharmacogenetic testing. Personalized medication approach. Genetic testing, drug selection, dose adjustment, monitoring and evaluation are some of the approaches to personalize the medications. Pharmacogenomics plays a crucial role in personalizing the Warfarin therapy. Warfarin is an oral anticoagulant which is widely prescribed and helps in prevention of the thrombosis-related complications. There are various genetic factors that influence the Warfarin response. They are
vitamin K epoxide reductase complex subunit. Patients with certain these variants require lower doses of the warfarin due to the increased sensitivity. Next is cytochrome P2C9 variant. The individuals with these alleles may metabolize warfarin more slowly, leading to the higher blood levels and increased risk of bleeding if standard doses are used. Next is pharmacogenomics in personalizing antidepressant selections. Antidepressants such as selective serotonin reuptake inhibitors and SNRIs target neurotransmitter systems in the brain and alleviate systems of the depression. Individual response to these medications can vary widely due to genetic differences. The key genetic variants are cytochrome P450 enzymes. The variants in genes affects the metabolism of many antidepressants. Serotonin transfer gene variants in this gene can influence how a person responds to SSRIs. By testing these specific genetic variants, clinicians can gain insights into how a patient is likely to metabolize and respond to the different antidepressants. What are the benefits of pharmacogenomics? Pharmacogenomics helps us to understand the personalized medicine, improved efficacies, reduce adverse effect, optimized dosage. What are the challenges and considerations? First one is ethical issues, limited availability, cost of testing, limited awareness, regulatory challenges. In ethical issues, informed consent, privacy and informed consent plays a very important role. Access in limited availability, access to pharmacogenomic testing is not universally available. Cost of testing. Genetic testing can be expensive and insurance coverage may not always be available and it creates a financial barriers. Limited awareness. There may be a lack of awareness among the healthcare providers and patients about the benefits and availability of the pharmacogenomic testing. Next is regulatory challenges. Regulatory challenges are still evolving around genetic testing and pharmacogenomics can create uncertainty for the providers and the patients. Pharmacogenomics holds a key to a future where medication is no longer one size fits all approach. The successful implementation of pharmacogenomics will pave the way for a more precise and effective healthcare landscape, ensures that all patients receive the most appropriate therapies for their unique genetic makeup.
Friends, we'll have a break. We'll take a break right now, and exactly at 11:30, our live telecast will start. Our talk will start from Boston. Okay, that will be shown telecast live. Meanwhile, I will introduce that speaker right here on the screen. It will start at 11:30. Short time break.
सर कनेक्ट करू दे सर कनेक्ट करू दे
हे झाले end पर्यंत. Well, 15 lectures. 12:15. Well,
ऐक रे हे आता कनेक्ट केल्याने नमक प्रेझेंट करते फक्त ते म्हाका लॅपटॉप प्रेझेंट करू
आता तुम्ही कनेक्ट करून जोडला
हय सर माहिती जॉईन झाली
ते लॉक झाले
ना सर ते जॉईन जावना ते समज जॉईन जाले न्ही मागीर म्हाका मेसेज येतली मागीर एडमिट करता मागीर ताकात आनी मागीर ते प्रेझेंट करता
हय बरोबर हय
ती प्रेझेंट करता मग आमी हांगच्यानसून पळोवं शकता
हय बरें
ए म्हाका सांग हांगा यो व्हिडिओ लायव्ह चालू म्हाका सांग प्रेझेंट हांगा तुमच्या
Hello. Hello, friends. Live telecast will just start now. He is already in Google Meet. Please come back to the hall. Please come back to the hall.
फोटो काहीच काढून
Hi, are you guys able to hear me?
Shiji. Hello. Hello. Yutika, can you hear me? Hello. Hello.
Are you guys able to hear me?
Yeah, can you hear me? Hello.
Yeah, I'm able to hear you. Yeah, I'm able to hear you. I'm not able to share my video though.
Yeah. I think you can take a start within another 2 or 3 minutes. Hello.
Yeah.
Yeah, you take a start after 2 3 minutes. We had taken a break. I have done a introduction of you. Okay. You start your talk after another 3 minutes. Yeah.
Okay, sounds good.
Hello.
Yeah.
Yeah. Can you
Yes, Dr.
Can you straight away start your talk after 3 minutes?
Okay.
Huh?
Hello, Miss Yuta. Hello. Are you showing your presentation?
Hello.
Put the audio and video on.
Both are also, but she's not ready. I can myself. She's not
Presenting, sir.
Oh.
She is
प्रोजेक्टर आहे प्रोजेक्टर आहे
आवाज
प्रोजेक्टर आहे
असं साईडून बोलला आहे ना असं साईडून बोलला
साइड तू एवढं आहे काय पोया कधी तू कंटाळ करतो किती रामा आपले रंग कपडी करपास विचारलं तिथे घाई घालपास घाई ऐकतली हे घालताना सगळी doesn't matter.
Hello.
yeah. You can
Yeah, we can see that slide. Okay. We can
Okay,
see
is
that
it in
slide.
presentation mode?
Yeah. Yeah.
Okay, thank you so much.
Yeah.
Okay. Yeah. So, hello everyone. A very good morning to you all.
One minute. You take a 1 minute. 1 minute. 1 minute, please.
Hi, Dr. Bar, did you say something?
Yeah, yeah. Just hold on for another 2 minutes or so. Another 2 minutes.
Sounds good. I can wait.
Yeah, yeah.
Yeah, could you please let me know when we are ready?
Yeah, right. So another 2 minutes you give us.
Sure, sure.
Yeah.
Okay.
Hello, Silvan. Hello. Ang dulo, sa mga ultas.
Hello. 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 Yutika, can you listen? You hear me?
Yeah, I can hear you.
Oh, okay. I think you start your talk.
Okay.
Yeah.
Thank you. So, again, hello everyone. I'm Ritika Jonathan Shipsa. I have been working in the CRISPR-Cas9 gene therapy field around Boston for over 5 years now. And before I start this I would like to say thank you to Dr. Vernon, Mr. Shashankar Rainmaker, and the college staff for having me here. It is definitely an honor to be presenting in front of this audience in this prestigious event. And I'll be giving a talk on unlocking the code, exploring the fundamentals of gene therapy. So let me give you a brief overview of today's presentation. I will begin by introducing gene therapy and its fundamentals, how it is applied, what are the current innovations and advances, the ethical and regulatory considerations, the future directions and challenges. Before we start talking about gene therapy, I was hoping to quickly give a summary on gene, as we are going to be talking about it in every slide going forward. So, as we all know, that inside the nucleus of the cell, we have the 23 paired chromosome that stores most of the body's genetic information. Now, each person typically gets 2 copies of each gene from their biological parents. So now these genes will control everything, from hair color to your height to many other traits. And humans have between 20,000 and 25,000 genes. So each chromosome is made up of DNA that stores information to determine our unique characteristics, and specific sections of the DNA are called genes. Now these genes, they will provide instructions on protein production, We all know that proteins, they play a very important role in body functions, and even if there is a small change to the DNA within our gene, it could alter how the protein works, and that will eventually affect the bodily functions such as digestion, eating, walking, etc. So now, what are these entities that cause the gene to alter? So these are called gene variants. So now genetic changes that occur due to cell age, exposure to certain chemicals or environmental factors, and these can also often be passed along from parents. Now the genetic variants, they are recognized and repaired, but there are other times when they could cause disease or disorder, and then the treatment is needed. So when we talk about gene therapy, the genetic material that we use or target is the DNA or RNA. So now, going into the introduction to gene therapy. Gene therapy, if we have to define it, it is a technique that uses a gene or genes to treat, prevent, or cure a disease or medical disorder. Now, it works by adding a new copy of a gene that is broken, or by replacing a defective or missing gene in a patient's cell with a healthy version of that gene. If we have to think about the history, it is very interesting. Right now, we have been talking a lot about gene therapy in the last decade, but it is very interesting to know that the concepts had already arose initially during the 1960s and early 1970s, when there was the full development of genetically marked cell lines and the full clarification of mechanisms of cell transformation by papillomaviruses, polyoma, and SP40 when they were in progress. Now, papillomaviruses, polyoma, these are a family of small DNA viruses that cause abnormal growths in animals and humans. And to speak for SP40, it is also called a simian virus, and it is associated significantly with brain tumors, making bone cancers and malignancies. Not only that, but also the recombinant DNA techniques also resulted in availability of clonal genes, and that not also demonstrated that foreign genes could indeed correct genetic defects and disease phenotypes in mammalian cells in vitro. So if we have to speak for gene therapy, we do think it's a revolutionary approach, because here what you're trying to do is you're trying to take care of the disease from its cause. You are targeting the underlying problem. Like most of the disease that we have now and therapy that we take for it, we're trying to subside the symptoms and trying to work around the problem that's causing it. But here we are trying to take care of it from its root cause. So definitely it's a revolutionary approach. Going into the fundamentals of gene therapy. So how does this work? Now we know when we look at tablets, we look at capsules, it's very easy to process them. But when we talk about genes, when we talk about cells, how does this work? So when we have to deliver a working gene into the cell, we use vectors. Now this vector is like a package. You're used to deliver a specific message. Now, usually viruses can be used as vectors because we know from example, like from the COVID-19, we have information or we are well aware that viruses have evolved to be very good at getting into cells. So they are usually used as vectors. The vector can be delivered in one of different ways. It could either be ex vivo or in vivo treatment. So when we say ex vivo, this treatment removes the person's own cells and then it delivers the genetic material to these cells outside the body. And now these modified cells are then brought to the body. When we say in vivo, this means that the genetic material is delivered directly into the person, such as fuel injection. Talking about gene therapy, there have been certain challenges and considerations. The biggest challenge in its development are its off-target effects. gene therapy targets the wrong DNA sites. We could want it to go to the right on-site target, but it could happen that there are off-site target effects. Now, these can result into a number of things. For example, chromosomal rearrangements. Now, what are these? These are deletions, duplications, and translocations that can cause genomic instability. Now, some chromosomal rearrangements are also known to cause human cancers, such as lung cancer. It also can result, these off-target effects can also result in the trigger of immune response. It can cause cytotoxicity. It can also result in misleading research results that is not reproducible. You could see a false positive result or a very good result, but you are not able to reproduce it. So that could be one of the indications of off-target effect. Then it could also result in health problems. Now, for example, if the gene is incorporated into a patient's reproductive cells, so now it could be passed on to its future generations. So it is a genuine problem. Having talked about it, we understand that it is right now nearly impossible to eliminate off-target effects in certain cases, but there have been strategies to reduce them. There have been improvement in specificity of single guide RNA, improving the Cas variants, using prime editors, using anti-CRISPR proteins. So we'll be talking about them in the later slides. So where is this applied? Gene therapy. Majorly now talking about vaccination. It has been accomplished through addition of new genes coding for key structural supplements of infectious particles. It is also used for a number of diseases such as cancer, Duchenne muscular dystrophy, Parkinson's disease, glaucoma, cardiovascular disease, diabetic retinopathy, to name a few. Currently, as of August 2024, there are 38 approved cellular and gene therapy products available, which is very interesting. So if I have to discuss a few successful clinical trials, I would like to start with Casgevy, since it's very special because I've also worked on this therapy. It is the first CRISPR-Cas9 based gene therapy for sickle cell disease, which received a breakthrough FDA approval. So for sickle cell disease, it's a hereditary hemogglobinopathy. It results from a beta-globin gene mutation that causes abnormal hemoglobin polymerization, and then this could lead to severe complications. So the current treatment options that we have, they primarily focus on symptom management, and it has very limited curative potential. With the introduction or with the having Casgevy in the market, these clinical trials have shown that it can be administered to patients aged older than or equally 12 years, and it enables precise modifications in hematopoietic stem cells, resulting in elevated fetal hemoglobin levels and a significant reduction in vaso-occlusive events. It offers a curative approach and eliminates the need for recurrent transfusions and transplants, improving the quality of life of patients. Having heard the stories from patients firsthand, we know how important it is and how much has it been a life changer for them. Because for someone who is going through sickle cell disease, they have to go through frequent transfusions, and they are not only painful, but it is also very difficult. Especially thinking back of COVID-19, when there were very limited human interactions. So it wasn't easy. So having Casgevy is definitely life-changing for these patients. The other clinical success that I would like to share is the Viscount-Aldrich syndrome, which also had benefits sustained for years following the therapy. So VAS is a rare genetic disorder whereby boys usually carry a mutation in a gene called VAS, which produces an important protein for healthy blood cell functioning. Now, people with VAS have low numbers of platelets, which results into experiencing serious bleeding with minimal trauma, also eczema, increased risk of infection, autoimmunity, lymphoma, and also that results in reduced life expectancy. Now, the only standard curative treatment for VAS is a blood stem cell transplantation that requires a suitably matched donor and it has potentially life-threatening complications. So again, like thinking of having a gene therapy for disease like this is definitely a blessing. So the current innovations and advances. So the journey of gene therapy has reached a fundamental milestone, as evidenced by the increasing number of gene therapy products on the market, and it is definitely a promising future. For example, the CRISPR-Cas9 systems. These have become the most favorite genome editing tool in molecular labs since they were confirmed to have genome editing capabilities in 2011. So to name a few of the gene therapies that are there, which are some of them are already approved in the market, some of them are going through clinical trials, and some of them are in the early research stage. So to talk about DNA therapy, the DNA plasmids, they can be used for gene edition, vaccination, and cell therapy. These DNA plasmids, they are large, double-stranded circular molecules that code for a therapeutic protein. Now, viral vectors. In this case, the viral genes are removed and replaced by functional gene sequence and packaged inside the shell of a virus. Viral vectors, these modified viruses are used as vehicles to deliver therapeutic genetic material or specific DNA sequences into a cell. Talking about RNA therapy, there are a number of RNA therapies out there. I'd like to talk about the mRNA therapy, which produces more of a specific protein. And for the mRNA therapy, usually a lipid nanoparticle is used as a container. Lipid nanoparticles deliver therapeutic mRNA into cells because its structure, it protects the contents from being degraded after being injected into the body. Then we have the small interfering RNA. These target a specific mRNA to prevent production of unwanted proteins. And the small interfering RNA, they are double-stranded RNA molecules. These therapies are designed outside of the cell to target expression of a specific gene. We also have the transfer RNA, which carry the amino acids to the ribosome to help make a protein based off the mRNA instructions. Then we have the suppressor tRNA therapies that are designed to override suppressors. They are designed to override incorrect mRNA instructions that may cause disease by stopping the protein production too early. Now, these suppressor tRNA, they are the binding they bind to the incorrectly made mRNA and allows correct protein to be made by the ribosome. Then we also have the control therapies. They act inside a cell to alter how proteins are made. They also silence a gene so protein is not made. It is for therapies, how mRNA is made, then change how a protein is made. These stay in the cell for a limited duration and they need to be given repeatedly to maintain a therapeutic effect. There are a couple of therapies, the therapies that are in the market. Then talking about cell therapy, it is the transfer of a specific cell type into a patient. The cells can come from either the affected individual or an unaffected donor. Now, an unaffected donor can be a healthy patient, a healthy person. So the cells will come from a healthy donor. Gene-modified cell therapy. It is a combination of gene and cell therapy. It first removes a person's own cells from the body, and certain cell types are then treated by either adding a working or healthy copy of the gene or modifying the editing the affected one. The modified or treated cells are then written to the person. So, therapy is a good example of a gene-modified cell therapy. So, the ethical and regulatory considerations, it is very important that we have ethics, especially when there is genetic science involved. So, ethical issues in genetic therapy involve the use of genetic science for human good and the avoidance of preventable harms. There are certain immediate issues that we should be taken care of. For example, the control and confidentiality of results of genetic testing. This is very important. This is very similar to the idea of using social media, where we want to make sure that our information is not leaked and it is kept confidential. So same goes with genetics. Then the other would be possible discrimination against those found to have genetic disease. It could happen that there are certain races, certain ethnicities where a genetic disease is very common. So there should not be discrimination against those. And the third one, this is less likely, but it is very significant. That is the use of genetic science in ways that go beyond prevention and cure of disease. Such use as trait enhancement and neo-eugenics that can raise troubling ethical concerns. Now, we all live in a world that values physical beauty, intelligence, long, healthy life. So, gene therapy might be misused in a eugenics movement that rejects any imperfection. So, this could be all the immediate issues that we come across. Talking about regulatory considerations, but just before deep diving into it, I was just hoping to just quickly do a recap of clinical trials and different stages of clinical trials. So we all know that there's a preclinical stage, also called as the phase 0, where we have data that is generated using animals, and companies or laboratories would have that information and they would apply for an IND, also called as the investigational new drug application, and would submit that information and the data to agencies or to the agencies in the world where they want to have their therapy sold or marketed. So now the agencies would review that data and would, after they have got the desired, if they think that it is satisfactory, then they would give an approval for the IND. And once the companies or labs have an approval, they would go into the clinical phase. The clinical phase again would be 3 stages: phase 1, phase 2, and phase 3. The phase 1 is where there is a smaller patient population and the safety of the therapy is measured. Then we have phase 2, where again the patient population is not huge, but we measure the efficacy of the therapy. And then finally we have the phase 3, where there is a wider and a larger patient population. And once all the data is collected, only then you get approvals from the FDA for the drug or the therapy to be marketed. So that was all about clinical trials and different phases. So talking about going back to regulatory considerations, it is very important for developers of gene therapy products to adhere to additional regulation that is beyond the traditional small molecule therapeutics. Again, because this is not like the small molecule therapeutics, this has a mechanism of action that is very unique, and it could have subsequent novel risks that could arise. Since this is again, it's a novel technology, so it's very important to adhere to the regulatory considerations. I also have a case study, a very interesting one about Glyvera, which also reminds us that just getting approval doesn't guarantee a drug success. Rather, regulatory challenges in some cases, especially in this case, has resulted in product failure. So it was, I think, in 2012 when Glyvera was recommended for approval. So submission before eventually approving the product. And then in 2016, it had only one commercial use, and it was only for one patient. So in early 2017, it was voluntarily withdrawn from the European market for logistical reasons. Now, Glabreda was the most expensive drug at that time in the world, with an estimated cost of 1 million per treatment. Now, the large price tag in combination with a very small patient population, and it also was not able to enter the US market due to FDA had its own skepticism of the drug's efficacy. So they did not have that approval. So again, emphasizing on the fact that they had a very small patient population, it proved that it was not financially appetizing. So it eventually failed. So again, just a reminder how important it is to have regulatory considerations. So talking about the future directions and challenges for gene therapy. Having worked on this field for more than 5 years now, I understand that it is a hope. It is a hope for fatal disease. Like gene and cell therapy can help treat disease that have limited treatment options. Without treatment, many of these inherited disorders would end in severe disability or premature death. But with gene and cell therapy, there are early studies that show that these disorders have been slowed down or completely stopped. The other future direction is earlier can be better. Like if gene therapy is received earlier in the course of a disease, it has the potential to stop any damage before it occurs. And there has been research that is ongoing to learn to what extent to which a gene therapy might reverse any damage. And as I mentioned earlier, that it is targeting the cause, it is targeting the underlying reason. So gene and cell therapies make it possible to design treatments that can target any of the thousands of genes in the body. So it has a future. Again, having talked about the future, definitely there are some challenges. We did say that it is a novel technology, so there are some challenges towards it. For example, the time. It is a lengthy process. Now, to test the potential treatments in clinical trials and then undergo the FDA approval process, it is definitely a very long process. It is also very costly, like how I mentioned about Glabreda, that at that time it was the first one that was approved in the market, and it was 1 million per treatment. So it has a high cost, gene therapy has a high cost involved, because it also involves like preparing the therapy for clinical trial, making a gene therapy, and then ensuring that it is carried out in the highest standard and the safety for participants. So it has a very high cost associated with it. Then we're talking about accuracy. Gene and cell therapies need to express the gene in the right ratio at the right level for the right amount of time. This means that a lot of research goes into the best way to deliver the genetic material, as we already talked about off-target effects and where they could lead, which could also lead to life-threatening problems. So it is very important that it is accurate, and for that very reason, a lot of research goes into it. And small number of participants. Now, gene therapy often targets rare disease. A small number of people with that disease, resulting in a difficulty in gathering enough research data or finding enough people that are eligible to participate in a clinical trial. It also will have long-term effects which are unknown. Gene therapy can be an alternation for a lifetime. There could be a long-term effect. It either could be good or bad, but that is unknown at this time. And for that very reason, gene therapies, they are monitored in a person for years following the treatment. and also repeat administration. It could happen that the delivery of foreign materials to the body can cause an immune response, and it may exclude patients from receiving the later treatments. It could also happen that there is a better treatment that comes up, but then the patient, because it had an immune response, is not no more applicable for that new therapy or the new advancement. So these are all the challenges. Conclusion. Having talked about it for a few minutes now, I would like to conclude that gene therapy has been around from the 1960s, if you think about it, and can be used for treating disease that were thought to be difficult to cure or incurable by knocking out, deleting a defective gene, or adding a correct copy or modified copy of a gene. Now, genetic advances and biotechnology breakthroughs, such as CRISPR-Cas gene editing, they have given gene therapy a new role in treating a broader range of disease. Unfortunately, as we already mentioned, that there are still some limitations, potentially the off-target effects, but there are many research teams, or there's a lot of research that's going on that is trying to improve this. There are ethical considerations surrounding the technology and regulatory frameworks, and they must be addressed to ensure possible application and equitable access to this one-time gene editing therapy. And I would like to conclude that it does appear that we have entered a new era, as evidenced by the increasing number of approved gene therapy products in the last decade. Thank you so much.
Hello, Yutika. Hello.
Yeah, I can hear you.
Yeah. I'll ask the audience if they have any question. I'll take one or two questions. And yeah. Anyone has any question on this topic? Yeah. Anyone has any question? Okay. Oh, Yutika, there are no questions. Thank you very much.
Okay. Thank you so much. I would again like to mention it's a pleasure and an honor to be presenting, and good luck to everyone. Thank you so much.
Thank you. Friends, we are continuing with the presentation competition, and we have the talk of right now scheduled to be after the lunch. Okay, so we have only 5 speakers. We conclude with the presentation, so that judges get enough time to finalize the result, and meanwhile we can listen to other votes. Thank you.
Ms. Sheetal Patil. After Sheetal will be Arshada, then Nisarga, then Simran, and Kirti. So now Ms. Sheetal Patil. Are you ready? Your time starts now.
Good afternoon, dear viewers. I am Sheetal Patil. Today I am here to discuss the topic how pharmacogenomics can be used in personalized medicine. In this presentation, I am going to key points. What is pharmacogenomics? What is a personalized medication? Why pharmacogenomics is used in personalized medicine? Why personalized medication is very important, and how pharmacogenomics can be used in personalized medicine. People can respond differently to the same drug because variety of factors like the weight, age, liver and kidney function of the patient, sex, other medication, and genetic difference. The study of how genetic difference affects the drug response is a pharmacogenomics. Definition of pharmacogenomics. Pharmacogenomics is the genomic profiling of the patient for genetic variants that clinically modify the tolerability and desired effect of the specific medication. Pharmacogenomics is a collaborative interdisciplinary effort which includes the clinical pharmacology, clinical pathology, and other clinical specialties which aim at optimizing the healthcare delivery by personalizing prescribing practice and patient care to improve the outcome. Then what is the personalized medicine? Personalized medicine is a therapeutic strategy that harnesses the individual genetic and epigenetic information to deliver the targeted treatment specifically designed for that patient. Personalized medication leverages the omics approaches such as the genomics, transcriptomics, proteomics, and metabolomics to elucidate the inter-individual variability. Then why pharmacogenomics is used in the personalized medication? Main purpose of pharmacogenomics is moving from one drug fits all to the personalized therapy. And the main goal of personalized therapy is right drug for right patient at the right time. When a group of people have the same disease and treated with the same therapy, then some people from that group get the effective treatment, some get the less effective treatment, some get the adverse effect, and some are unaffected by the treatment. So when a group of people having the disease are tested from the pharmacogenomic study and getting the data from pharmacogenomic study, if we provide the personalized medication treatment to each patient according to their genetic variation, then each patient gets the effective treatment from the personalized medication. Then how pharmacogenomics can be used in personalized medicine? For development of personalized medicine, pharmacogenomics first interpret the genetic makeup that analyzes the individual unique genetic profile to understand the disease predisposition and the response, and this understanding aids in the discovery of a new drug and helps in selecting the most appropriate treatment for the patient. And this provides the insights for customizing the dosage regimen and promoting the development of personalized treatment plans for the optimal patient outcomes. Pharmacogenomics mainly focuses on the genetic enzymes only because they play a very important role in the metabolism of the drug. Because these enzymes impact how medication is processing and eliminated from our body. Any slight changes or variations in this genetic enzyme affect the rate of metabolism, difference in the therapeutic effect, side effect, and toxicity across the individual. There are a number of enzymes present in the body which involve in the drug metabolism. Example: cytochrome P450 enzyme, UCT gene enzyme, cell gene enzyme, GST gene enzyme, LAT gene enzyme, thiopurine S-methyltransferase enzyme. And among these enzymes, cytochrome P450 is a primary enzyme which involved in the approximately 90% of the drug metabolism in the human. The human gene encodes at least 57 different CYP enzymes and which are organized into 18 families and 43 subfamilies. And among these, CYP1, 2 and 3 families are primarily responsible for the metabolism of 80% of clinically used drugs. Example, CYP1A2 is the family of a cytochrome P450 gene which metabolizes the caffeine, theophylline and some antipsychotic drugs. Whereas CYP2C9 metabolize the warfarin and non-steroidal anti-inflammatory drugs. CYP2C19 metabolize the clopidogrel and proton pump inhibitor drug. Whereas CYP2D6 metabolize the antidepressant and opioid drugs. And CYP3A4 or 5 involve the metabolism of many drugs including the statins and benzodiazepines. Depends on the different activity level of these enzymes. Patients are classified into different metabolizers like ultra-rapid metabolizer, intermediate, extensive and poor metabolizer. Ultra-rapid metabolizer have increased enzyme activity, so they metabolize the drug fastly and result in reduced drug effectiveness because drug cleared from the body too quickly. Whereas the intermediate metabolizer have reduced enzyme activity compared to extensive metabolizer, but metabolizer. Extensive metabolizer are also known as the normal metabolizer because they have a normal enzyme activity and metabolize the drug normally. Whereas the poor metabolizer have a reduced or absence of enzyme activity. So they have reduced or slower metabolism. So this leads to a higher drug level in the body and increase the risk of adverse events. Depends in the enzyme activity level, different metabolizers respond differently to the same drug. Example, codeine is a commonly used analgesic after the labors of pain associated with the episiotomy and C-section. But in 2006, Lancet published a case report that in April 2005, full-term healthy male infant was found dead on day 30 after a vaginal delivery because the mother had been prescribed codeine and paracetamol for episiotomy pain. Pharmacogenomic study reveals that mother was the ultra-rapid metabolizer due to her CYP26-2A and CYP26-2X2G duplication, which increases the conversion of the codeine prodrug into active form of morphine. This increasing level of morphine from the mother body system will be converted to the baby through breast milk, whereas the infant is an extensive metabolizer with the CYP26-1 or STAR2 allele, which likely suffered from the opioid toxicity and neonates cannot effectively metabolize the morphine. Such a type of adverse drug reaction can be controlled by using the pharmacogenomic study in the personalized medication. Steps involved in pharmacogenomic study: physician order for the test, then collect the biological sample from the patient like saliva or blood, then various genetic analysis tests will be carried out in the laboratory, and by the genetic analysis data integration, physician should review the data and develop and prescribe the personalized treatment and educate the patient. Give examples how pharmacogenomics can be used in personalized medication. Pharmacogenomics is used in the personalized medication of the cancer treatment because genetic variation in the genes such as the BRCA1, 2 and T5, T3 are linked to the increased risk of the breast and liver cancer. Personalized detection and therapies can be developed based on the pharmacogenomic testing of these genetic variants. Example, trastuzumab used for the breast cancer patient with the HER2 positive tumors because this is targeted therapy specifically binds to the HER2 protein on the cancer cell, inhibit their growth and the survival. Second, pharmacogenomics play very important role in Alzheimer's disease also. So in conclusion, pharmacogenomics balance the personalized medicine and give the various advantages like the improved drug efficiency, reduced adverse effect, optimized diagnosis, faster response, and lower health costs. These are the references which are used for my presentation. Thank you.
Marcela Susani. Marcela, are you ready? Start.
Good afternoon, everyone. Myself, Ashita Kusani. Today I am going to present on the topic of how pharmacogenomics can be used to personalize the medications with examples. Let's see the contents. These are the contents: introduction, principle of pharmacogenomics, patient groups, then benefits and challenges, how pharmacogenomics can be worked, then the biomarkers and the impact of the pharmacogenomics in the personalized medicines. And last one, that is the genetic variations and the response of the drugs. Let's see the first one. What do we mean by the pharmacogenomics? Pharmacogenomics is a study of genetic variation which affects the individual response to the medications. And then personalized medicines are the medicines which are right medicine at a right dose for a right patient. The pharmacogenomics which utilize the information of genetic to give the safe, effective, and accurate dose without trial and error process. Next, the individual variability with the drug response means what? In traditionally, we have group of patients giving same prescription with the same diagnosis. So it's showing some toxic effect, some showing beneficial effect, some showing toxic with beneficial effect. So overcome such limitations, the personalized medicines are introduced. These are the difference between personalized medicines and without personalized medicines. Without personalized medicine having some benefits and some do not have, and with personalized medicine which having correct medicine, so it's having all the benefits. Next, that is the principle behind the pharmacogenomics. The principle behind the pharmacogenomics, it depends upon the chart, four parts. That is the genetic variation. Genetic variation is for the variation in the DNA which causes or which impacts on the drug response. It produces impact in several ways, like single nucleotide polymorphism, then copy number variation, insertion and deletion, and the gene expression variation. These are the genetic variations. Then the genetic impact on the drug response. It is the genetic variation which impacts on a drug response. So it is the metabolizer status like ultra rapid metabolizer, poor metabolizer, and intermediate metabolizer. Then the drug target variability and the transporter variability. These are the genetic impacts on a drug response. Then the pharmacokinetic and the pharmacodynamic. The genetic polymorphism which impacts on the pharmacokinetic and the pharmacodynamic process. Then the types of the pharmacogenomic testing. The pharmacogenomic testing are the three ways. That is the genetic testing, genotyping, and phenotyping. Next, the applications of the pharmacogenomics or the advantages of the pharmacogenomics. That is the predict patient drug response, then minimize ADL events, then increase efficient patient compliance, then drug dosage accuracy. These are the advantages of the pharmacogenomics. Then the challenges in the genetic testing like complexity, high testing cost, and ethical concern. Next, how pharmacogenomics are works. As I told in the pictogram, traditional medicine and the difference between the traditional medicine and the personalized medicine. In the personalized medicine, first we are testing of the DNA, urine, and blood data is collected and the testing is carried out based on the genetic variations can be understood, and based on that the personalized medicines are prescribed. So it gives the accurate medicines to the correct patient. Next, there is the biomarkers. Biomarkers are the biological markers can be used to measure the process at the cell and molecular level, which helps to give the correct medicine to the correct patient. Next, these are the impact of pharmacogenomics in a personalized medicines. Based on the examples, we can understand the impact of the pharmacogenomics on personalized medicine. Like therapy, probiosis, factor V redox is a specific gene mutation that results in the thrombophilia. So we can avoid in such conditions like thrombopoietic drugs. Then the kidney transplant and the invasive fungal infection. In this, the poor metabolism of viriconazole occurs predominantly. So we can alter the agents like which reduces or the which lowers the metabolism. Next, with the genetic variations and the response to the drug, we will see with the examples like the carbamazepine and oxycarbazepine, gene like HLA-B, increasing this which causes a severe dermatological reaction like Stevens-Johnson syndrome. Then warfarin, that is CYP2C9 star 4 and CYP2C9 star 3, which increasing this which decreases the warfarin metabolism and leads to the bleeding. Like Vicor C1, which increases in Vicor C1, which causes increasing warfarin sensitivity and leading to the bleeding. Next one is celecoxib, CYP2C9, increasing CYP2C9 star 3, which decreases celecoxib clearance. So such drugs which should be avoided or decreasing the dose. Next, there is a cartizumab and the trastuzumab. These are HER2. If it is tumor is positive, then it should be prescribed. If it is negative, then it should be avoided. Then the 6-mercaptopurine and azathioprine. that is the TPMP gene. If it is decreased, the increasing risk of myelosuppression, drug should be given at a low dose or it should be avoided. Then the 5-fluorouracil or Pharmacogenomics, that is the DPD, decrease in DPD, which cause severe toxicity like diarrhea or neutropenia. Last one, it is a cetuximab, that is a TRAS mutation. If it is positive, it gives response. If it is negative, it do not give response. These are the some drugs which are showing which give effect on the genetic variations. These are the references of my study. Thank you.
Miss Nisarga. After Nisarga is Simran and then Kitty. Nisarga, are you ready? Your time starts now.
Good afternoon, everyone. Today, we are diving into the fascinating world of genetics, the science behind who we are. And this is Nisarga Sitigi, who would like to take this opportunity to deliver my presentation on the topic pharmacogenomics. As we all know that each one of us respond differently to the drugs, the food that we eat and the drug that we take. The drug which is effective in one person might not that effective in another person. The drug which is safe for one person may be dangerous for another person. So what are the key reasons for this differential response of a drug towards an individual? So for that, first we need to know what is this differential drug efficacy. Suppose there is a group of patients, and among this group of patients, the doctor finds out the same symptoms, same findings, and that is concluded that they have a same disease. So for those same disease, doctor prescribes the same drug with the same dose. But when he observes the effects are found to be different. The drug, even if it is efficacious, even if it is effective, but when we prescribe the same drug of same dose to different patients, the effects are found to be different. A drug might be efficacious in most of the people, the drug might not be efficacious in others, that is lack of efficacy, and the drug may be harmful in few, that is unexpected side effects may be seen. So as drug shows different effects on different individuals, people react differently to the drugs. So there is a patient population with same disease phenotype, and there are millions of genetic variations which exist. When we genotype them, there are three different responders towards the drugs. In the first group, with the black and the smiley, they are the patients with drug toxicity. They show unexpected side effects. The second group, with the gray one, they are the patients with non-response to the drug therapy. It's like we are prescribing them the drug, but their body is not responding, neither positive nor negative. It's like we are giving them a placebo. The third, the white group of individuals, they are the patients with normal response to the drug therapy. Now the question arises, why does this drug response vary? So there are multiple coordinated factors for this drug response to be varied. There are ethnicity, age, pregnancy, genetic factors, drug interactions, co-medications, that is presence of other drug during the treatment, and then body marks. Among these, the most important factor is the genetic factor, which occurs due to variation in the gene sequence. So this is usually denoted as SNP. Polymorphism is a variation in a sequence present at an allele frequency of 1% or greater in the population. So there are majorly two types. One is SNP, that is single nucleotide polymorphism, and insertions or deletions. The SNPs are the locations within the human genome where the nucleotide present differs among the individuals. Maybe in one individual at one place adenine may be present, and maybe in another individual at the same place guanine may be present. So there is a difference in the nucleotide present in an individual. These SNPs occur roughly every 300 nucleotides, and there are three types. One is harmless, there
will be no change in the phenotype, and they may be harmful. They will be harmful in the diseases like diabetes, cancer, Alzheimer's disease, and they may be latent. That is, SNPs might be found in coding region and regulatory region. If these SNPs are found in coding region, they might alter the protein structure. Like in case of sickle cell anemia, there is a single gene mutation due to which the whole protein structure gets changed. And now let's see the difference between genetics versus genomics. Pharmacogenetics is the study of variability in the drug response determined by the single gene. The main goal of this pharmacogenetics is to see how well a medicine works in his or her body. We study the genetic makeup of an individual person and see how well a medicine works. It's like right medicine for the right person. Pharmacogenomics is the study of variability in a drug response determined by the multiple genes within the genome. Now, how does genetic variation affect the drug effect? Patients' response to a drug may depend on the factors that can vary according to their alleles. So there are two levels at which these factors play a very critical role. They are pharmacokinetic and pharmacodynamics. In pharmacokinetic, there is ADME, that is absorption, distribution, metabolism, and excretion. In pharmacokinetic, first the dose is administered, which is absorbed in the systemic circulation where the concentration increases. It is further distributed in the tissues via blood circulation, and then it is eliminated to liver for further metabolism and excretion. Whereas in pharmacodynamics, with enzymes, immunity, and ion channels, they are target proteins and downstream messengers. Here, the drug reaches the particular target tissue, and then drug reaches the particular target tissue and it shows some pharmacological effects. They might be toxic or they might be effective. Pharmacogenomics helps us to in individualized medications and personalized medication. In future, this field of pharmacogenomics will help us to develop a tailored drug, which is helpful in treating various healthcare diseases like Alzheimer's disease, cardiovascular diseases, and many more. The basic challenges to the drug design. So there are two individuals, Tom and Perry. In Tom, the pathway A is leading to the progression of hypertension. In Perry, the pathway C is leading to hypertension. There is another pathway which is pathway B. The two drugs, drug X and Y, are prescribed. In drug X, drug X is targeting the enzyme 3 on pathway A, whereas drug Y is targeting the enzyme 9 on pathway C. When the drug X is prescribed to all the three individuals, it will be effective only in the individuals who are in pathway A but not in B and C. Similarly, goes to drug Y, it will be only effective in the pathway C but not in A and B. So we'll see one of the prominent example, which is Warfarin. Warfarin is sold under the brand name Coumadin, which is an anticoagulant and which is used as blood thinner and which is used to treat strokes in people who have atrial fibrillation and vulvar heart diseases. Consumption, we basically consume it through mouth and it can also be given through injections through veins. So this Warfarin basically inhibits this vitamin K reductase enzyme, which is responsible for conversion of precursor prothrombin into active prothrombin, which leads to thrombosis. This vitamin K which is present, it gets oxidized to form vitamin K epoxide with the help of an enzyme, vitamin K epoxide reductase enzyme, which is responsible for conversion of precursor prothrombin into biologically active prothrombin. But when this Warfarin drug is prescribed to the patient, it inhibits this enzyme, that is vitamin K reductase epoxide enzyme, and hence there will be no leading to the thrombosis. Safety of Warfarin: major risk is bleeding, frequent and severe. Relative risk: fatal extracranial bleeds. Out of 100 patients, majorly 2 to 3% of patients show major episodes of bleeding. DNA testing for Warfarin sensitivity has been done. There are 2 polymorphic genes which are responsible: C1b2, C9, and DKOR. The FDA Pharmacological Subcommittee has recommended DNA testing for these 2 polymorphic genes for Warfarin consuming. Warfarin metabolism: there are 2 polymorphic genes which affects the Warfarin metabolism response: allelic frequency, ethnicity, which is responsible. There is a concern of prescribing this Warfarin drug to the patients. That is, overdose can lead to bleeding, which can be fatal, and underdose can also lead to thrombosis, which is fatal. These are some of the sources of data and search engines which I have reported. Thank you so much.
Ms. Imran Rani. Imran, are you ready? Your time starts now.
personalization, where every aspect of our life is personalized, including our mobile phones, our vehicles, electronics, and even the food items. But what about our medication? Imagine a world where your treatment is not based on what works best for everyone, but it is tailored specifically for you based on your genetic makeup. Well, the question that arises is this possible? Can we actually personalize medication? And if so, what are the key tools which will help us to achieve this? Good afternoon, everyone. I'm Simran Rani, and today I'll be talking about how pharmacogenomics can be used to personalize medication. Before we move on, we need to understand what pharmacogenomics is. So, pharmacogenomics is made up of two words: pharmacology, which means the science of drug, and genomics, which is basically the study of genes and their function. So, we can say pharmacogenomics is the study of how genes affect a person's response to drugs. It helps us to develop effective and safe medication that can be prescribed based on a person's genetic makeup. Now that we know what pharmacogenomics is, let us understand what is personalized medicine. Imagine, will a grandchild buy the same clothes as his grandparents? Probably not. But if they happen to fall sick, what then? They are likely to receive the same medication as everyone else. What does this lead to? This basically leads to a one-size-fits-all medical approach, which is sometimes not good because it's based on a broad population. Imagine a treatment which is specifically tailored for you. So basically, personalized medicine is an emerging practice of medicine that uses an individual's genetic profile to guide decisions made in regard to the prevention, diagnosis, and treatment of diseases. There are various parameters and factors which influence how drugs respond. One of the factors which influence drug response is cytochrome enzymes. The cytochrome P450 enzymes are major players in drug metabolism. Some of the examples are cytochrome 3A4, cytochrome 2D6, etc. Now, these enzymes have multiple genetic variations. That is, each individual person has some genetic variation in these enzymes. And this can help us to personalize medicine. Now, let us understand how cytochrome enzyme can help us to personalize medicine with an example, clopidogrel. So clopidogrel is an antiplatelet medication which is used to prevent blood clots in patients with heart diseases. It is a prodrug, so basically it requires to be activated by a liver enzyme, cytochrome. So how can we use this for personalizing medication? So genetic variations, particularly the CYP2C19 gene, affect how well patients respond to clopidogrel, making it a prime candidate for personalized medication. So depending on the genetic variations, we have three metabolizers, that is normal metabolizers, the intermediate metabolizers, and poor metabolizers. Normal metabolizers respond well to the standard clopidogrel doses, whereas intermediate metabolizers have reduced enzyme activity, and poor metabolizers very low enzyme activity. There are various genetic testings available to figure out your genotype, and one of them is this for clopidogrel. The tailored treatment is normal metabolizers continue on static clopidogrel therapy, whereas poor and intermediate metabolizers may require alternate antiplatelet medication. Some of the advantages of this tailored treatment are improved outcomes, reduction in adverse events, and optimizes the effectiveness of antiplatelet therapy for each individual patient. Example 2 we have is Herceptin. Herceptin is basically a monoclonal antibody which treats the HER2 positive breast cancer patient. It works by binding to the HER2 protein and it blocks their ability to send the growth signals. How can we use this to personalize medication? So basically, Herceptin is only given to patients whose tumor will overexpress its HER2 protein, making it a targeted therapy that is much more effective for the specific group. I would also like to mention that October is the Breast Cancer Awareness Month. So there are various diagnostic tests which are available, such as the IHC, immunohistochemistry, and FISH, fluorescence in situ hybridization techniques, which helps us to determine if a person with a breast cancer has the HER2 proteins or not. So tailored treatment would be HER2 positive patients benefit significantly from Herceptin, and also there are reduced side effects because unlike chemotherapy, which affects both cancerous and healthy cells, this therapy will only target the specific cells. So in conclusion, pharmacogenomics will allow us to customize drug therapy based on an individual's genetic makeup. It serves as a key tool for personalized medication. The key benefits are optimizing drug dosing, for example, drugs like clopidogrel, which helps us to determine the right dose. We also have improving drug selection. Certain genetic markers such as that of HER2, which is present only in HER2 positive breast cancer patients, it will help us to guide which medication should be given to patients with these markers. And lastly, we have reduced adverse effects. So this personalized medication will help us to avoid serious effects by adjusting or avoiding certain medications. In summary, pharmacogenomics personalizes treatment, ensuring the right drug at the right dose for each individual, leading to safer and more effective healthcare. These are the references. As the era of one size fits all comes to an end, and the era of personalized medication takes place and comes over, the question is, are we ready to embrace this new transformation, and are we ready to lead this future of personalized medication? Thank you.
Ms. Kirti Madhekar.
Hello.
Kirti, are you ready? Your time starts now.
Good afternoon, everyone. So today I'll be talking about how pharmacogenomics can be used to personalize the medication. Now, before coming to pharmacogenomics, let us see what is genomics. So genomics is nothing but the study of an organism's entire genome. That is, the study of the genes, the interaction among the genes, as well as the interaction with their surrounding environment. Now, the gene will include the DNA, that is nothing but the hereditary chemical code, which will have a set of instructions for the further growth and development of the organisms. Now that we know what is genomics, I would like to take this opportunity to thank the scientist who is none other than Fred Sanger, who in the year 1962 began his study of genes and therefore coined the term as genomics. Now coming to pharmacogenomics, it is defined as a combination of pharmacology, that is the study of the medicines, and genomics, that is the study of the genes. Pharmacogenomics is used to determine how the gene of the person will affect their response towards a medication. Pharmacogenomics can also be used to determine or to provide a safe and effective medication by understanding the genetic makeup of the person. Now that we have understood what is pharmacogenomics, let us see personalizing medication in patients. Now, for example, if we consider a group of population that is diagnosed with the same disease, for example, diabetes, is provided with the same prescription, that is, the same drug for the same frequency, having the same dose. A part of the population will experience the drug toxicity with a beneficial effect and drug toxicity with no beneficial effect. However, a part of the population will experience no drug toxicity but the therapeutic effect and no drug toxicity with no therapeutic effect. So this picture depicts the situation wherein when a large group of population is provided with the same medication, some patients will show the therapeutic effect, some will show the adverse events, whereas some will have no effect at all. So here pharmacogenomics come into picture, wherein by studying the genes or the genetic makeup of the person, we can tailor or design the medication that is suitable for that particular patient in order to provide the maximum therapeutic effect with minimum or no adverse effects in the patient. Now, in addition to genes, factors such as the age of the patient, ethnicity, weight, gender, the disease state, and the level of the disease can also be taken into consideration while personalizing the medication. Coming to why pharmacogenomics is important. So pharmacogenomics
pharmacogenomics is important because it speeds the time in achieving the therapeutic response. It will help to prevent the dependency as well as the side effect. It will help to maximize the intended use of administration by improving the patient compliance. It will help to reduce the adverse events that can take place. And most importantly, it will help us in selecting the most suitable and affordable drug in treating the patient. Coming to some of the common pharmacogenomic testing technologies, that is the techniques by which we can study the gene or the genetic makeup of the person. So first we have a standard sequencing technique which is used to determine the DNA of the person by chain electrophoresis, followed by real-time PCR which is used to detect the fluorescence that is produced by the PCR accumulation. Coming to the next technique would be the microarray, which is used to determine the sequence of thousands of genes at the same time. And last but not the least, next generation sequencing, which is a process where the DNA and the RNA molecules are fragmented, a suitable adapter molecule will be added, sequencing the library, followed by reassembling this molecule in order to produce a genome that is suitable for treating the particular patient. Now let us see the various technologies by which the genetic makeup of the person can be studied. Let us come to how pharmacogenomics can be used to personalize the medication. So it can be first used for optimizing the drug dosing, for reducing the adverse events, for improving the efficiency of the drug, selecting the right drug for the patients, in tailoring the treatment for pain management, in case of cancer therapy personalization, and last but not the least, for the cardiovascular disease treatment. Our first case for today would be pharmacogenomics in tailoring the pain management. Now, codeine is one of the most commonly used drugs to treat mild to moderate pain and belongs to opioid analgesic. Now, the enzyme known as the cytochrome P450D6 is responsible for metabolizing this codeine to its active metabolite, that is morphine, which is responsible for producing the analgesic effect. Now, in the patients that will have more than two inactive enzymes, there will be no proper conversion of this codeine to morphine. Therefore, there will be less analgesic effect. However, in the patients that will have more than two active and functional enzymes, there will be better conversion of the codeine to the morphine. Therefore, better analgesic effect. However, this can also be associated with the morphine overdose due to the more rapid conversion of the codeine to the morphine. Therefore, there can be fatal consequences in the patient, and therefore, pharmacogenomics plays a very important role in understanding the genetic makeup of the person so that we can design or tailor the medication that is suitable in only providing the therapeutic effect. Coming to a second case, that is pharmacogenomics in treating the colorectal cancer. Now, panitumumab is one of the drugs that is used to treat the colorectal cancer. Now, it will bind to the epidermal growth factor. It undergoes the internalization, intracellular processes, which causes the increase in the apoptosis, that is, the increase in the cell death, which causes the decrease in the tumor cell proliferation, followed by the decrease in the angiogenesis, that is, decrease in the supply of the nutrients and oxygen taking place through the blood vessel to the tumor. These processes will ultimately lead to the decrease in the further growth of the tumor. Coming to the pharmacogenomic market 2024, it was observed according to the US market that in the year 2024, 39.4% of the market was captured by the DNA sequencing segment, followed by the microarray, electrophoresis, etc. Also, 40.2% was captured by the sequencing segment, whereas 10.3% was captured by the personalized medicine segment. Coming to the future of pharmacogenomics in personalizing the medication. So, current medicine is one treatment fits all. That is, one treatment given to all can cause the adverse effect or the therapeutic effect or the no effect in patient. Our focus should be on more personalized diagnostic in the future, such that we can design the drug that will only aim at providing the therapeutic effect with no side effect or the adverse effect. So, I would like to end the session for today with a quote. That is, pharmacogenomics is like a personalized puzzle for your medicine. It studies how your genes will affect on the way you respond to medication. Thank you.
At the end of our presentation competition,
lunchtime, and we invite our esteemed guest speakers, judges, college teaching staff, college staff accompanying Karnataka students, participants of the presentation competition, and volunteers to join us for a deep-looking homemade lunch. And we will resume back at 2 o'clock sharp. Thank you. Thank you very much. Hello. Lunch time is 1 to 2. We are resuming back at 2 o'clock sharp.
राजन सरांना अडिले आम्ही
Good afternoon, everyone. So we resume our seminar session, or rather we start our seminar session. I would like to introduce you to two speakers speaking on one topic. Actually, the two speakers name Mrs. Pratnya Kalakuttar and Shreyas Kalakuttar. They are the two. Pratnya is a student of this college. She passed out BPharm at this college and MPharm through KID Bangalore. Shreyas passed out this BPharm in Goa College of Pharmacy and MPharm in KID. They are going to speak on different avenues open for people stressing and passive why we should join LLB or MBA after B.Pharm or M.Pharm. And Pratya will tell you on overall the avenues open after B.Pharm. Let me introduce you to May I request Kazi if he has to come? Please hand over the flower to Pratyana and okay, Kazi, you will take over.
Hello everybody, myself.
तो हे काढ.
Myself, Pradnya Kalangurkar. I'm working in Center Pharmaceuticals in Quality Assurance Department. I studied in this college for the year 2009 to 2013 batch, and I'm very glad to meet all my teachers, the principal and the staff, and also my batchmates who have now become teachers after so many years, like almost 10 years. So, since I'm slightly feeling unwell, Mr. Shreyas will take over the topic.
So good afternoon. It's a very hot time after lunch. Post-lunch sessions are always quite sketchy, I understand. But I try to not make this dosing of session. Let's make it interactive one. So yes, my name is Shreyas Kalangurkar, and yes, like Dr. Bharat has said, this college is a special college to me because my wife has studied from this college, and thanks to all the teachers, whatever they have inculcated is showing. And yes, thank you, Dr. Bharat, for the kind introduction. I think you also saw the cute kid that we have. His name is Intranasal. So coming to the topic that I am asked to present on today, I'll just clear that I am no guru on career guidance or career advice. I can't offer much in this area, but what I can offer is 10 years of industrial experience and how to cope up and how to navigate through that process. When we say a winning combination, it's usually a combination or an aspect of 2-3 parameters or processes that comes together. Like in this case, what you need is the right skills, knowledge, and strategic career choices. Now, to achieve a good career in in the pharma field, you need to have the right skills, the knowledge behind the skills, and have a clear career path. It's not only in pharma, it's usually in every other field that we see around. Take for example cricket. MS Dhoni, I'm sure everyone knows him. He has the right skills. He has the knowledge about his subject, that is cricket, and the strategic career choices. I'm sure all of you have seen the movie MS Dhoni. There's this scene where he waits for the train. Like he's at the train station and his train is about to leave, and he has two choices. One, become a TC for his life. Two, get on the train, join the Indian team, and the rest is history. So these three the combination of these three aspects is what makes the defining point. Coming to technical skills, now let's just go in depth in the skills part. So what are technical skills? the strong knowledge of pharmaceutical sciences. So I'm pretty sure this college makes a very good effort in giving the proper education guidance, so as the other colleges go. Your research and analytical skills. Now, these are your skills ready to develop on the research aspect of your prospectus, like your data analysis, your interpretation of the data. Over time, if you have developed these skills, you go a long way in the pharma field. Your familiarity with the regulatory guidelines. Now, we all know that the whole pharma field is governed by GLP, GMP, ICH, and other guidelines. Now, these guidelines keep on changing over time. It's not same. Like GLP, GMP, like GMP when we were studying was GMP, now it is GMP. A few years down the line, we still improve it. It's a continuous process. There are additions, there are deletions. So you have to be familiar with these guidelines because they serve as the Bible for us. Understanding the pharmaceutical technology, like formulation, manufacturing, the QC. When you say understanding the pharmaceutical technology, it's merely the process from your dispensing of the raw materials to your finished product in the market. And it doesn't end there. It's also beyond the market. Like you have to take continuous follow-ups with the vendors, with the products. Coming to soft skills. Now, soft skills, by the term, are not soft to touch. They are skills that are defined like effective communication, like the verbal skills, the written skills, the presentation skills. Mind you, this might seem simple, but it's really an interesting topic. Like I've seen people fumble with words, I've seen people fumble with their presentations. It's very important to know and to put forth what you want to, what you are grasping and what you want to tell the auditors or whatever the concerned person is. Now we have audits. Pharma companies are constantly scrutinized the auditors. So now the auditors directly want to connect and talk with the bottom line people, like the analysts, the scientists. They just directly want to have word conversation with the scientists. And in this case, if you fumble there, it's really a tough situation. You have to be clear with what you want to say. And these skills can be developed. Your interpersonal skills. Not only in pharma, in your life, it is very important to have these skills like your teamwork, your collaboration, the conflict resolution. Even during your school, your college, the project works that you are given, it's very important to have this teamwork efforts going on. Your problem solving and critical thinking skills. Now, this shapes how you go ahead with what you are given. For example, let's just say like you are loading a system and you encounter a problem, like you are loading an XPS system and you encounter a problem where you are not able to attain the desired response, you are not getting the peak. What do? You're stuck. Like if you have the proper subject knowledge, if you have the knowledge about the subject, if you know what you are doing, and if you have this problem solving attitude in you, it's easy. Trust me, it's very easy to maneuver through. Problem issue, do something, mobile fix, change it, adjust the concentration, you can do it if you have the proper knowledge behind it. Your leadership and management. Now this goes a long way. It's not just in the initial stage, but this would take you up into the extent where you can be a actually you can own the company. You can be the one of the board members also. I know people in my circle who have achieved this only and only because they have worked on their leadership skills, their managerial skills. Further down the slides, I'll explain also how MP can help us achieve this, combining it with the Pharma founding. Your adaptability and flexibility, it is unsaid, it's self-explanatory. Pharma is an ever-changing field. There is no stagnancy ever. Every day the guidelines says every day there is something new that is introduced. You have to have this flexibility and adaptability to achieve your goals. Business acumen. Now, understanding of the pharmaceutical industry trends and the market dynamics. We all know what demography is. Pharma is ruled by demography. A drug that might be widely used in India may not be used much in the country that you are targeting to sell it in. So it's very important to know your demography, to understand the trends and the market dynamics. And the market dynamics also keeps on ever changing. Like we had COVID 3 years back. Everyone knows that the sales of sanitizer, the sales of masks was on the rise in during that time. So that was because of the changing market scenario, the changing market dynamics. Knowledge of pharmaceutical marketing and the sales strategies. This goes hand in hand with the topic I just mentioned. Your familiarity with the business operations like the finance, the supply chain management, these skills, if you develop, you have a good opportunity at shop floor and also in the procurement section of the pharma industries. Your data analysis and statistical interpretation, like the hypothesis testing. Now, these are business acumen skills where you develop in hypothetical software. Like we have softwares and you can put scenarios in it and you have hypothesis testing in it. So in such cases, the analysis of the data and the interpretation of it is very important. A simple example of this would be, I'm sure people must have used chromatography here, like HPLC and all. So HPLC is just the machine part. The main part is the data analysis part, which comes post-analysis. So you give your run, the analyte goes to the column, it detects, and the detector gives a response. Now that response is then interpreted to a software. To name a few, it's Chromium, there's Empower. So this software then interpreted. Now the software will do its part, but it's upon the technical skill of the person who's analyzing it to interpret it in proper terms. The software will give you the area of the peak, whatever it is, maybe in thousands, 5,000. But then it's your job to interpret it and see whether it is matching your assay value, whether there are impurities in it, whether there is negation of or degradation of the peaks. That's up to you. That's your skill. That's how you develop it. Digital literacy. Now, like proficiency in MS Office. I know and I've seen people in the pharma sector where they fumble with basic Excels and basic formulas in the Excels. So if you have your proper digital literacy, if you have your skills in this, it can also be quite a good amount of aid. Familiarity with ELNs. So I'm sure this might be a new topic to you. So electronic lab notebooks are notebooks, like how we have journals at our work. So these are ELNs at pharma factories. So they have software oriented ELNs. So when you directly enter your value or whatever your results are in the ELNs. So earlier, in few years back, there were these manual LMDs where you record, you do your testing, you write, or if you take a batch, you weigh, you do the process of dry mixing, granulation, reducing, you write it down. But now, all the pharma companies are moving towards electronic notebooks, where you just have to enter your code number, your employee ID, and the value, whatever you paid. Like if you have done any process, you just enter it and it comes in the proper MPCR format. Now, MPCR is master production record file. So control record. So that is your MPCR, which has all the data of your batch. So LNPs helps you with that. All the pharmas are now slowly turning towards the LNPs. Like Cipla has already started, Sanofi has started, Union has already implemented this, Glenmark is starting it. So if you have your skills and digital literacy in this, it will be like an added advantage to you. It will be like a boon to you. So you won't have to adjust much when you are out there. Computer design softwares. These I've just spoken about, like the HPLCs, the whatever analytical softwares or other software that help you analyze the data. database management, SAP. So SAP is another software. It's called system-based application product. So most of the companies, most of the pharma companies, not only related to pharma, most of the companies use this SAP software, wherein they maintain an inventory of the goods, receipts, your APIs, your excipients, your raw materials, everything that is procured in the pharma is goes through SAP. Even the release part, the batch release, everything goes through SAP. So it's a software, it's complex to use, and it is complex. So, but if you have background of it, if you can get a few tutorials, the tutorials are available on YouTube as well. If you can get tutorials on it, it will be very helpful for you. So basically my concern to tell you is be aware of this digital things, this digital terms and softwares that might help you in your career. AI and machine learning. Now, AI and machine learning is slowly becoming an integral part of our life. Be it cell phones, be it mobiles, be it your other electronic gadgets, even pharma. Everything now and slowly shall be oriented towards AI and machine learning. The machines that are now introduced in the pharma line will have AI and machine learning. So if we have a first-hand experience in what is AI, how to maneuver it, how to use this to our advantage, we can definitely do this. Coming to the career, these were all the skills that you all get. These are like the 3 major skills. Coming to the career choices, I'll just brief you through the career choices. So we have academic, that is the further studies, industries and allied industries. You can offer marketing and distribution, drug administration, state, central, entrepreneurship, that's business, and there are other areas. Coming to academics, you're getting the quote, like how Nelson Mandela first said, education is the most powerful weapon which you can use to change the world. In education, we have MPharm, MBA, PharmD, MS. Just out of curiosity, how many of you all here are MPharm students? Can you please raise your hands? The rest are people, right? Quite a lot. Good to see this. So I am a firm believer and in the fact that you always have to have a master's degree in whatever you are studying. So it's always advantageous to have a master's degree. People opt for other things after BPharm, that's fine. But I personally believe having a master's degree in what we have studied is always advantageous. You can, yes, combine it with other degrees, which we'll see in the forthcoming slides. So coming to MPharm, there is pharmaceutics, ecology, QA, pharmaceutical RA, pharmacy, clinical, medicinal chemistry, and much more also. This I do not need to tell you, like I'm seeing a lot of MPharm students. So yes, these are the MPharm subjects that we can have our studies in. MS, coming to MS, this is a Masters in Science program. These are mostly held abroad, outside India. So these are the two most common MS programs, that is MS in Pharmacy and MS in Biotechnology. They are equivalent to MPharm, but foreign countries prefer it to be called as MBA. Now coming to MBA. So MBA we can have marketing, that is product management, pharmacy, MBA, health and management, and pharmacogenomics. Now there are institutes like NIMS, Narsimunji, wherein they have a program for MPharm and MBA. So after your BPharm, you can opt for MPharm MBA program. It's a very good program wherein you get your MPharm degree as well as you get your MBA degree. Why MBA? So if you have an MBA degree to your BPharm or an MPharm degree, you get enhanced career prospects. You get your doors open to project roles like product management, project management. In mind you, these are very important roles. These are very high paying roles in the pharma sector. You can have your own business setup since you have the go-to knowledge about the business processes. It opens doors to wider range of career options beyond pharma industries, as I've said, and it has a very high earning potential. It is unsaid. It is a given. Like if you have an MBA degree, you automatically have a higher earning potential. The PharmD degree, that is the Doctorate of Pharmacy. Now, this is minimum 3 years degree, wherein the 2 years are your study years, 1 year is your internship year, and these are mostly used for clinical studies. Like you have the opportunities in clinical trials, and they are more focused on the clinical pharmacy practice and the patient care practice. LLB. Now, this is a very interesting topic where you can add this to your M.Pharm or a B.Pharm degree. Where you have a first-hand experience at law. So you also get your LLB degree, that is your legislative law degree, and it equips you for a legal career. You can specialize in pharmaceutical law, IP laws, and other such laws related to drugs. Now we know that India is a very emerging market, and it's a full-fledged war out there for pharma companies. And in such companies, you always and at very frequent intervals of time tend to have IP patents. So now what are IP patents? IP is the intellectual property rights. So if I own a company and I have an IP or an intellectual property, so meaning I own that property. If a drug manufactured by me, which is patented by me, is in the market for like 15 years. For 15 years, I am exclusively the owner of the drug and no other company can copy that drug. Once the 15 years is over, then there is that battle that starts of all the companies because it's out there, the product is out there in the market for the first one to claim it. So you can claim the product with your product, saying it is better or equivalent. So then it is out there. So this is where this legal practice come into picture. It's a dog in dog world out there. Let me be honest. So if you have a first-hand experience in the legal law, aiding to your B.Pharm or an M.Pharm degree, it's a very good advantageous field. Because pharma companies, they are like mongers for such degrees. So if you have these degrees, they just take you. Compliance issues. So when you have this, you have a very strong knowledge and you can navigate through compliance issues. The compliance issues arise when you have an audit to your company or your firm. Now, auditors, what they do, they check by their order. Like for example, if the US FDA is auditing you, for them, it is a code of federal regulations, CFR. So, CFR is their Bible. So, what they do is they check each and every aspect of that company, whether it is fit for production of the drugs and goods in their country. So, like in this case, US. So, they will scrutinize your product from the start of the raw materials to the market complaints that you have received once the product is already dispatched in the market. All the batches, no matter how many batches there are. So now here, if they have any compliance issues, then you get what is called as a warning letter. And once you get a warning letter, it is downhill right from there. So if you have this knowledge, if you have the knowledge about the law and the compliance and things how to maneuver from this, you can very well save your company and the firm from such a loss. Identifying potential legal risk in business comes hand to hand with the point which I described first in IP wars. So if you have a potential legal risk which can be foreseen, so you can very well avoid it with this knowledge. Forensic science. So your degree can also be combined with forensic sciences, wherein there are specialized expertise in application of scientific principles in the investigations. Now it is like I always have seen CID, not like Dr. Saluki, but this is something better. There are law enforcement agencies, forensic labs, forensic pharmacists, identifying counterfeit drugs, drugs related to crime, and poisoning incidences. So this all can be easily dealt with if you have forensic sciences knowledge. These are some of the top colleges in India and abroad.
They don't have two of my favorite colleges, which is PS and GCP. Not buttering anyone, but yes. These are the marketing distributions. Now, you can have a career in marketing and distribution. Like you can be an MR, a medical representative, a sales executive, service engineers for pharmaceutical engineering, instruments and equipment, drug wholesalers, and medical writers. These are aspects other than the ones which I have described before. Drug administration, state and central, wherein you can opt to become a drug inspector, provided you clear the necessary exams for it. Your drug control laboratory analysts, regulatory affairs officers, compliance officers. Now, compliance officers, like how I mentioned before, audits. Like few pharma companies tend to give contracts for their products to other companies, where they manufacture the products on loan basis. So it's called loan licensing. So you can become a compliance officer and then have audit visits to these companies and then establish these companies to be competent as per how you require them to be, as per your product needs. Entrepreneurship or self-business. This is self-explanatory, where you can set up your pharmacy stores, whether online or offline. You can become a pharma raw material supply agent, multi-service storefronts, mobile pharmacy, wholesale of medicines, import and sales of medical equipment, devices, surgical product marketing and supply. These have high value in the market, in the retail market, and you can opt for them as well. Coming to the pharmaceutical industries and allied industries. Now, here I have listed the various departments in the pharmaceutical industries. So, as I've said before, the skills, the knowledge, and the right career choices, if you all choose it right, you all can ace in any of the department that you all choose here. To name a few, it's production, QC, QA, your warehouse, compliance control, regulatory affairs, project management, R&D, corporate QA, microbiology, then HR and admin, sales marketing, clinical research, pharmacovigilance, and drug safety. Coming to this industry insights, like in the pharma sector, R&D, so that's the research and development. It's from where I belong. It's a very long road and a path from the drug discovery to the final drug in the molecule. We see the drug products in the market, but we do not see the research and the efforts that has gone behind it. It takes about 15 years for a product to be developed in the market and then be marketed. It starts from your discovery, where you identify the potential drugs and the drug targets. For example, if you are targeting a market, you first identify which are the products that the market needs or the market has a huge supply in. Also, you have to check your profits. Once you have zeroed in on the product that you are going to manufacture or discover, it's synthesis and formulation development, where you synthesize a molecule if you can, or you export it from any supplier that gives the supplies the material. But the formulation development is where you develop the product, you develop the formulation, you develop the OSD, the form, whatever, and then you develop an analytical method to test it and validate it. Once the whole validation process is complete, when you know that whatever your drug is claiming is what you are getting, you proceed further to the clinical trials. Now, clinical trials can be, these are preclinical trials, wherein it is in vivo and in vitro. Vitro being in the lab, in vivo being on humans or on test subjects. Then there are clinical trials wherein there are human testing. It's divided into phase 1 to phase 4. Now, phase 1 is wherein you have clinical trials on a few 50, 20 to 100 subjects. Phase 2 is when you expand the group a little bit into hundreds. Phase 3 is where you go on thousands of people and testing as a whole in a hospital pharmacy. That's the stage 3, stage 3. And stage 4 is the post-market analysis, wherein you have a product surveillance post the product is in the market. So it's a continuous process. Once the product is in the market, you do not close the door on the product. You have a market surveillance post your product is in the market. Pharmacovigilance is what is very important here. Just to add a case study, you all must have heard about thalidomide poisoning. Anyone? No. So thalidomide poisoning is the first case. It's the first basis case for pharmacovigilance in the market. So after the thalidomide case was brought to light, the pharmacovigilance was then developed. So what happened was, this was during the World War II, post-World War II, wherein this drug called as thalidomide was used for people who were not able to sleep, who were not getting sleep. So it was a sedative. So it was widely used because people were experiencing PTSDs, post-traumatic stress disorders, after the war. So many people were using this drug as a sedative, and it worked. It worked wonders for them. People who had these PTSD syndromes, it really worked wonders for them. What happened once was, it was once prescribed to a lady who was going through a similar experiences of PTSD. The lady was also experiencing morning sickness, which she was expected. She noted that her morning sickness was drastically reduced by the dose of the thalidomide. The doctor, what he did, he started prescribing thalidomide to all the pregnant ladies that were coming to him. Soon word spread that this drug, when given to pregnant ladies, it ceases the motion sickness. What happened then was, as this woman started to deliver babies, the babies were born without legs. So this was a very scary scenario wherein almost all the ladies who were administered this drug faced with babies without legs. So a huge worldwide investigation was going on, and it was narrowed down to the product called as thalidomide. So the pharma company already sold the product in the market, but there was no post-market surveillance which brought this incident to light. And since then, it gave birth to pharmacovigilance. That was just out of topic, but it felt necessary to address it here. Post-clinical trials, we have regulatory approvals. So regulatory approvals are like your regulatory agencies like FDA for US, EMA for Europe. So these have certain set of rules wherein you have to abide by them if you are selling your product to them. It's simple, like if you like how the European agencies told Apple to introduce a seafood. They would just not accept the type of seafood. So now Apple had to introduce a seafood. So that is how these agencies work. Their rules are their rules. You cannot challenge them. You have to adapt your product to fit their rules. Only then will they accept your product in their market. So these are all the regulatory approvals that there are tons of regulatory approvals that are to be addressed and needed before your product is filed in the market. Like you have to perform a multimedia resolution studies of your product in varying pH. Then you have to have a set of DMFs, right from your API synthesis, the route of synthesis, the impurity, the nitrosamine content, the elemental analysis content. All these dossiers are to be submitted to these regulatory agencies. Once they do it, only then they give a stamp that your product is ready to be sold in the market. And then subsequently there is launch, wherein you have market introduction, your commercialization of the product, your advertisement, and so on. Now, the goals of R&D are to develop safe and effective treatments, to improve the patient outcomes, to address unmet medical needs, to drive business growth and innovation. These are the basics. Like any R&D that is set up should have these goals, and they do have these goals. But what are the challenges? R&Ds have the highest failure rates, obviously. Because if you are about to develop a new product, you do not know how the product or the molecule will behave. It's also to be mentioned here that now Indian pharma sector is mostly a generic pharma-based sector, wherein the R&Ds that are Indian pharmaceutical sector mostly and majorly target the drugs whose patents are about to expire. So, for example, Crocin, if you take a paracetamol tablet. So, paracetamol tablet, for example, if I own the paracetamol tablet for 15 years, I am holding it. Once the 15-year patent is complete, it's out in the market. So, all these pharma companies, they target for that molecule because they know the value of the molecule in the market. So one pharmaceutical company X would produce their drug product, company Y will produce their drug product, and then you have to claim that your product is either better or equivalent to the market product. So that is the generic product. So in this case, you have a very high failure rate because sometimes you fail to match the dissolution profile or the efficacy rate of the product already established in the market. So this is what the statement means. Long development timelines. As I mentioned before, it takes about 10 to 15 years for a product to be developed at R&D and then commercialized. The high cost involved, about 2 to 3 billion per drug development, and the complexity, competition, and patents. Regulatory complexities, as I mentioned before, competition, and the patient's work, patent wars. Coming to the insights of production and testing. Now, production is like the money pumping factory or money pumping money pumping portion of the pharma company, wherein R&D would you invest something in the R&D for a 10 to 15 years and then you'll get your fruits. But in production, you get your fruits right there and then itself. Like there are sections like GMP, GLP, compliance, regulatory standards, your process analytical technology, PAT, that is the real-time monitoring and control. Process analytical technology is the technology wherein you, right from your starting material, that is your dispensing of the raw materials, to your finished product, we have a continuous set of tests on the way and at regular intervals to check the integrity of your product. There is tests like IPQC, like when you are punching your tablets, when you are having a bulk volume, bulk density test, you are having a leak test to check the integrity of your packing material. And there are other types of tests that are involved in this creative technology. Your continuous manufacturing process, your supply chain management, and your analytical method validation and testing. Coming to analytical method validation, any of you all here are for pharmaceutics and QA? Empowering pharmaceutics or QA? Raise hands here. So I'm sure you already might be developing a test method and then validating it for your project. So what validation means is you give a set of procedures, a set of tests to prove that your method is repetitively giving you the right results, which it is aimed at measuring. So audits and inspection is also a part of production and testing. Your regulatory affairs. So familiarity with the global regulatory agencies like the FDA for US, European medical agencies, EMA, WHO, Anvisa is for Brazil, and SABRA is for South Africa. So these are like the major contenders in the market. Where is Brazil, South Africa, FDA, US and Europe, these are like the major markets where people invest in, the pharma in India are investing in. Understanding the regulatory guidelines, so CGMP, GLP, your ICH guidelines. A tip for all the students here, if you are going for pharmaceutical industrial background, industrial career, then it is wise enough to just get a gist of all these regulatory guidelines for your interviews because it helps. Your awareness of emerging trends, your knowledge of clinical trials and the regulations. Now, we all know pharma is a ever-emerging market, so it's just about, every day there's a new thing that is introduced in the market. Every day there's a new guideline. Every day there's a deletion of a section or a point from the guideline. So we have necessarily be aware of it and keep ourselves updated. The clinical research and trials. So clinical trial design and methodology. So you have to here you have to develop a clinical trial study design, your site management and monitoring, and your data management and biostatistics. What site management means? Most of the pharma companies give their clinical studies to a third party hospital organization. For example, there is Virgo. So Virgo deals with clinical research organization. It's a hospital sort of pharmacy where you give your test product to be studied on human subjects for Virgo. Then you have to develop a design, you have to develop a methodology, and you have to develop a dose strategically design. Wherein some patients will be administered the placebo, some patients will be administered the drug dosage form, and some will be intermittently administered drug dosage form. And you have to, on a routine basis, check the concentration in their bloodstream. You also have to check the alcohol effect, the fat and the fasting effect. So all these things are the basis of the design model. Supply chain and management. So the global supply chain logistics, the QC and QA logistics, the inventory management, your cold chain management. There was this incident wherein most of the pharmaceutical companies had their production on a standstill because the only canal leading from eastern countries to the western countries was having a blockage because of the ships. So that is where your cold chain management comes into picture. Wherein how you have to design, how you have to manage the supply of your product to the final recipient of the country. Coming to all the takeaways that we have just discussed, make informed career choices. It's very important to have a clear set of goals. Like I remember my time 15 years back then, I was clueless right after the from India. I was very clueless, like what would my future be and where I would go. I opted for Infant, I joined the pharma company. Luckily, I got in the R&D section, and now I can say with the 10 years of experience that I have, that an informed career choice makes a huge difference in your career path. Develop relevant skills and knowledge. Very important and the most important part of today's discussion. If you have the perfect and the proper set of skills, there is no big deal. You all must have seen, like, if a bike needs to be repaired, you wouldn't go to any mechanic. You go to the mechanic who is skilled in that job, who would know what he's working on, who has the subject matter knowledge. Same applies here. Network effectively with industry professionals. Nowadays, there are platforms like LinkedIn where you can network and effectively, form connections with industry professionals. Stay competitive in the job market and effectively communicate and collaborate. Lastly, stay updated with the latest industry trends. To end the note, Mr. Ranchod Das Chachar infamously said that success के पीछे मत भागो, excellence के पीछे भागो. Success छक मार के पीछे आओ. Strive for excellence and the world is yours. Thank you. My contact card is displayed here. You can connect me whenever you want with any queries you have in regards to pharma or anything that you want to have second opinion. Thank you.
Thank you, sir. Thank you, sir.
May I request any next speaker for today's evening, Mr. Tarun Lakmani. He is manager IFP and he is in charge of IT department. He does all the software for the machines and he is going to speak on AI, today's AI use, benefits for healthcare and pharmaceuticals. Before, yeah, Shashank Thakur, please. Shashank, okay. Now,
Hello, am I audible? Okay. So if you Google what time of the day is the sleepiest time of the day, what would be the answer? It's actually 3 p.m. So initially, when I got this opportunity, I thought the timing of 12 p.m. So I was relaxed at least I will not have to work on my presentation. But then it got changed to 3 p.m. I don't know why. So I have to rework on my presentation to make it more attractive so that you guys don't sleep. Okay. So the topic is artificial intelligence, and I think this is something which in previous session also it was mentioned why it is important and why we have to work on it. Before starting this, I would like to know from you guys, do you think AI is around you? Can you give me some examples where you think AI is there? Any example is fine. ChatGPT. Okay. Anyone else? Any example? Anything is fine. You use Instagram, right? Any AI in Instagram, Facebook? friend suggestions, right? So all these things are actually the artificial intelligence. But this session will explain you artificial intelligence is actually an hype. The concept behind the artificial intelligence is actually the stats, which in the previous session also it was mentioned, while you guys have to work on the data analysis part. So this meme will tell you, as it indicates, everything which we call as an AI is a mathematical problem behind it. So you reframe it and make it a machine learning model, and then which we call it as artificial intelligence. So the foundation is the stats. We somehow modify it to call it machine learning, and when we have the audience with us like this, we call it artificial intelligence. Although it is a hype, there are some things which we as a human cannot do with our basic knowledge of maths, which are identify patterns, make predictions, and deliver insights. Now, I know most of you will be not in favor with this. You might be considering yourself as more intelligent, but this session is all about proving this, that at some particular time you will have to switch to artificial intelligence. Okay, this is my favorite guy, Celsius. Okay, he has designed a thermometer. Very simple. 0 degree for boiling water. Sorry, 0 degree for freezing point and 100 degree for boiling water. Am I right? Am I right? Okay. 0 because the least temperature the water can attain is 0 degree Celsius. Okay. And the highest temperature which the water can attain is 100 degree. Very simple, no complication. But then his friend came, Fahrenheit. He told, like, no, 0 is okay, like water, but I can achieve a point below 0 with the use of water, salt, and ice. Okay, I'll not go behind the chemistry of it, but 0 is 0 Fahrenheit is considered that, and 32 degree became the point of freezing point of water, and 212 is the boiling point of water. You all know this, right? So how do we convert Celsius to Fahrenheit? What is the formula? Something 9 by 5 or something. How you got this? Don't say Google. How you got this? Okay. So I'll show you the traditional approach, how we basically calculate it, and then how with the help of AI we can get this. So when these two guys were fighting to convert from 1 degree to another, this was what mathematicians had done. So they came up with the formula by calculating the slope from x-axis, y-axis, use maths, and then this is the final outcome, which you can now find in Google, and you know by heart, this is the formula. So this is actually a function which can give you the Celsius from Fahrenheit or Fahrenheit from Celsius. Okay? Only maths, no artificial intelligence in it. So what we do in traditional programming is we give the data and we have with our hardware model which can convert this, and then you will get the output. Okay, is it clear to everyone? But in machine learning, what we do is we give the input. Okay, along with input, we give some output which we know, and we don't give the output which we don't know. So in this, we don't have to do maths or anything. It will just give you an answer within few steps. You don't have to be a mathematician for calculating the value for 38. So what is there is we give the input to the function and the output which we know. It's all about the data which you know. and we will make up something which will give you this formulation. So we will calculate the data first. You take both the thermometer, get the data. We will do the model development and then we will train it. So we will see how we do this later. So what we do in machine learning is we have the sample data and we have the expected result. We prepare a model with it. And we then use this model with our new data, which value we don't know. And then we finally have the result. This is the difference in the approach. Okay. So now that was a very easy problem, right? Now the second problem is recognizing this handwritten digit. Now, if I tell you, if I write in a paper my a digit from 1 to 9, will you be able to recognize it with any maths? We can do it, right? So what we can do is we can see wherever the 8 is written, that will be considered as 0. Where it is not written, will be considered as 1. But I write 8 like this. And I'm sure you being the doctors, you will also write something like this. It will not be very clear. So the difference is, in the first problem, it was very simple for us to calculate it. Whereas in the second problem, it is not easy for us to recognize the digits. So this will not work for the problem 2. And you think from yourself how you started recognizing this. So I started recognizing this from my mom, who kept on getting me very long answers, and finally I know how to recognize this. I'm sure you all might have done the same thing. So this is what machine learning is. You give the data, it will create a model for you which will finally classify it. You don't have to do anything on your own. Okay. So why those examples were given to you? If someone tells you AI is there, machine learning is there, you don't firmly believe it. You first see whether that problem can be solved by you by using maths. If you know Excel, you can do it, then fine. But if not, you have to take help of some machine learning tools which are there. Okay, so we will see how this approach is useful in radiology. Okay, so this is the CT X-ray scan of tumor. A is benign and B is malignant, and third one is the normal tumor. So how we know this? By calculating the size, shape and contrast. Very easy, no artificial intelligence involved, right? Simple. But why we are calling nowadays like AI is, the radiologist is taking help of AI to predict the lung cancer. Anyone? If it is this simple, why AI is being used in this? How AI can make it more useful? Saying something? The thing is, this image is of later stage cancer, which can be easily seen, which is visible clearly. We don't need artificial intelligence. But we know lung cancer is the deadliest disease, and the early prediction can help in various ways. It can be very helpful for us if we can detect it, if we are able to detect it early. That's where AI comes in. The problem in the traditional approach in this is the diameter size will not be standard. It also depends on the appearance of the nodules, and all the CAD softwares which you will use will give us the different results. And also, once you have the nodule, it will be difficult for you to classify which are benign and which are malignant. And that's why we heard more and more of artificial intelligence taking control of lung cancer. Radiologists taking good help of this is because the same approach, like in recognizing a disease, they were using artificial intelligence. Same way, these X-rays are taken up by the model, and even the smallest and tiniest nodule can be detected by this. So this is the difference from traditional approach to artificial intelligence approach. And wherever the text is highlighted with blue, those are actually the tools being used currently. So for medical imaging, these tools are being used, which has some of the key features. For example, cognitive assistance. If you write a sentence, the machine learning model will detect what it is. Okay, for example, we have this text. So this is the screenshot of IBM Watson tool. The radiologists have written a 62-year-old woman presents for diagnostic mammography with a pulpable in her right breast. Describe the finding. So the model will take the key notes and then it will analyze the image, and then these are the knowledge base which it will use for shape, density, margin, and finally it will give you the answer. So all the analysis is done by the software itself. Okay, so this can be a second guide to the radiologist, which can be very helpful if used in the proper way. Okay, so make sure you are aware of these tools which are being used, so that when you come to that stage where you are actually diagnosing this, you are smart enough to do this. Okay, then similarly we have other applications in pathology. Now because we had time constraint, I have a video for you to play. Can you play? What? Thank you. Later. Meanwhile, so the principle will remain the same. Traditional approach will be used when we are able to classify it. But if it goes beyond our hand, it is not easy for us to do it. The factors are huge. Then we take the help of artificial intelligence. Similarly, same way we deal with this in pathology.
Contain advanced information. 3. Time-consuming, very fatiguing.
Every cell needs to be examined. Sometimes cancer is very difficult to recognize.
We had the idea for the microscope project 1 year ago. It brings augmented reality into an existing microscope to detect cancers in real time. We're bringing AI directly to the user, meeting them where they are right now.
I think this is going to enable almost all pathologists to have access to machine learning.
Just a few weeks ago, we got working into it.
It has a camera, so it's seeing the same thing I'm seeing. Information is being fed into a computer, which is doing billions of calculations and telling me that's the tumor, that's not the tumor.
Right now, it detects breast cancer, prostate cancer, but it can also work on any other cancer type that we train models for. The knowledge that you're getting in the microscope comes up cancer to you is the knowledge of many pathologists who contributed to training machine learning model.
team of pathologists that run through thousands of images, teaching the computer what cancer cells look like.
I think it has been very effective at locating areas of concern. It's like getting a second opinion.
It's going to make the doctors much quicker. They're going to make them better, which is going to overall benefit the patient.
The mission is to increase the accuracy and availability of cancer diagnosis and safety advice. I can hardly think of anything that's more motivating.
The audio was quite bad, but what they were saying was they were sharing their experience, how the introduction of machine learning helped their patients, and they were sharing how it is enabling them for faster diagnostics. Okay, we'll move on to next session. So I have shared 3 problems with you. There are some terminologies which I use. For example, artificial intelligence, machine learning. ChatGPT example given by you guys is actually a generative AI. So what happens is when you guys are reading an article on AI, you might not be able to understand few words. Or someone talking about AI, you might be not interested in those because you are not understanding the concepts. So now what I'm going to tell you is all the terminologies which we use in healthcare industry, and any article which you read will definitely have these concepts there. Okay, so you will better understand the article if you read in future. So first one being the head of all artificial intelligence. I told you any system which started acting like human, we call it as artificial intelligence. So this is a big umbrella, and all the concepts come inside it. So for example, IBM Watson is one of the another widely being used in internationally. So again, this is a patient case where a 60-year-old male with a 30-pack year smoking history has cancer and some mutation positive. He reports of weight loss and has not undergone prior cancer treatment. So what IBM Watson will do finally is it will tell the doctor the entire treatment that can be done along with the order in which it can be done, along with the accuracy to which it detects. So stage-wise, how it does is, it takes the help of guidelines which are available, as well as the local guidelines of the hospital which we give, as well as the evidence which are there. For example, the inclusion-exclusion criteria, any contradiction, or even the last session, Sir has reported FDA risk factors are also to be taken care of. And all the published literature which are linked with this will be taken care of by IBM Watson. So first of all, what it does is it takes all the key attributes from the case. So doctor will write only a statement, and the machine learning algorithm will get all the key attributes. All these details will be taken care of automatically. Then it will take the options from the clinical guideline. Then it will search all the supporting evidence, and finally the analytical algorithm will give us the treatment options as well as the evidence profile to the doctor. Okay. Then inside it comes machine learning. So it's a subset of AI. The problems which we have seen before, the thermometer one and recognizing the digits, those are machine learning related. In healthcare, there is something called AlphaFold. Any one of you are aware of it? It's a project by Google's DeepMind. So it will give you the 3D structure of the protein. So you might be knowing like making a 3D structure of protein is not very simple. You have to keep track of the amino acid sequence and all those things. It is as like you are given to develop a 3D structure with the materials which has to be used. So you will not be able to use those materials to make the 3D structure, right? So that's why this tools come into play, where you will be able to download any protein 3D structure, and this is free of cost and easy to use. You can download any protein 3D structure and use it in your research. Okay. So next will be deep learning. So this is a neural network, exactly how you perceive environment. You see a cat and a dog, you will be able to distinguish it. You touch any cup, you will be able to know whether it is cold or hot. A special case of neural network is formulation neural network. It only deals with visual data. So there is one model free of cost available where it will help you to diagnose the pneumonia with the X-ray of chest. So there are around 1 lakh of X-ray images along with 14 diseases which you will be able to predict. Then there is something called supervised learning and unsupervised learning. Supervised learning basically means where we know what to do. We tell the model this is what we want. For example, our thermometer case, we were telling them we already have the Fahrenheit, we want the Celsius. In unsupervised learning, we don't tell the model what we want. It detects automatically. One of the example of unsupervised learning is the spam. You all use the Gmail, right? There is something called spam folder. And you will see you have not changed the Gmail and you have not reported any mail, even then it is able to recognize the spam. This is the deep learning into play where all those mails are getting automatically generated as spams, filtered as spam. Okay. In healthcare, the data set where we know which image contains tumors is a supervised learning because we tell them this is the tumor, this is not, and all those things. And unsupervised learning means if we have a group of patients and we have to divide them based on their genes or based on their disease, that can be done automatically. Then there is something called reinforcement learning. The way a dog learns from you, similarly the model can be trained by you. So you just have to tell them when they are doing good, and you have to tell them when they are doing bad. Okay, so there is one tool called Microsoft Project Maneuver, which will take the help of the environment, the treatment, and the feedback which is given by the patient will help them to make it more comfortable. Then this is computer vision. We have seen how it is linked with deep learning. AI Doc is one of the tools which is used in emergency rooms to prioritize which are the critical cases. Then we have the NLP. So there is one app called Diabetic Cube as an example. So it will tell you what diets you have to take and what exercises you have to do daily, so that you don't. So basically, it will manage your diabetes. Then we come to generative AI. So ChatGPT is one of the examples of generative AI, and I'll show you how it is being used currently. So what generative AI does, it creates their own data content. So you need not to give the content to the model, it will create one for you. Yeah.
Generative AI is transforming healthcare with synthetic data, unlocking high-quality, unbiased data from medical device companies, pharmaceutical companies, and academic medical centers, leading to faster discoveries and improved patient outcomes. Generative models can help identify complex disease mechanisms, predict clinical outcomes, and prescribe tailored treatments for patients. Modi, the framework for building and deploying medical AI, is also advancing generative AI with methods to create large synthetic data sets for training
So this was one of the example in backend how generative AI will be used. Even if we don't have the images of X-rays or CT scans, we can automatically generate it. That's why if you see mostly this is in hype currently, everywhere the generative AI is trending. And this is the second use of generative AI where customers will actually use it rather than the doctor. And how it will be used, it will be clear with this video.
Hi, Sarah. I'm Rachel, your AI care manager. How are you doing after your appendectomy? You know, good. Glad to be home with my dog, Dennis. It's great to hear that you're back home with Dennis. I noticed that Dr. Chang has prescribed you some antibiotics, specifically ciprofloxacin and metronidazole, due to your ruptured appendix. Were you able to get these medications? I was. I did forget to mention to the doctor that I am allergic to penicillin. Is it still okay to take the medication? Great question. The antibiotics you've been prescribed, ciprofloxacin and metronidazole, don't contain penicillin. So it's perfectly safe for you to take them. Can you begin taking them today? Yeah, I certainly can. Do you have any tips for faster recovery? Given that you have diabetes, keeping your blood sugar levels in check will be beneficial for your wound healing. Your hemoglobin A1C was at a healthy level of 5.5, but your glucometer readings from yesterday were a bit on the high side. So keep taking your metformin and try to steer clear of foods high in carbs. How does that sound to you? I think I'll be able to avoid the carbs for the week. I need to go right now, but it was great talking to you. I'm glad we had this talk.
So I know audio will not be very clear. So the lady had some doubts in the medications given by the doctor, and since doctor was not teachable, the doctor had given a tool to the patient. So any questions related to the medicines can be taken up by the assistant, which we call as virtual assistant. So this is how the generative AI is playing a good role from the customer's perspective as well. So now, in the previous session also, drug discovery and development was one of the key factors, and this will be the last use case which we will see. So if you were listening to the previous session, so you know how many years it will take for the drug discovery and development. What was the number of years he has mentioned? Anyone? Your options are 3 years, 5 years, 10 years, 15 years. So everyone was listening. Okay. So we start with drug discovery, then it goes to preclinical, then it goes to clinical trials as explained, then the regulatory approval, and then post-marketing surveillance. This is the problem which we are facing is in the drug discovery, we start with around more than 10,000 compounds. And with preclinical, we come up with 250 compounds. So 10,000 is converted to 250. And then only 5 compounds are able to pass in the clinical trials. And with the regulatory approval and all those other approvals, only 1 compound finally made it up to the market. And that too with post-marketing surveillance. So which takes around 3 to 6 years for initial stage, then 6-7 for clinical trials, then more 2-3 years, and then 2-3 years for post-marketing surveillance. Then finally the drug or medicine reaches the patient. Now tell me one thing, which is the most critical stage? Where is the which phase of this entire timeline should AI focus? Which is the most critical? Is it drug discovery, preclinical, clinical, regulatory, or most marketing? Yeah, drug discovery, because this is where we need help. Because we are struggling with so many compounds, and even if we are wrong with even few percentage, our entire journey will fail. Till we reach one compound, finally we will realize we have made a mistake initially. So this is where we need the help of AI, so that when we move to clinical trials, we are confident enough that the compound reaches there is good enough to go to market. So in drug discovery, there are target identification, lead generation, lead optimization, and preclinical trial, and AI can help in these. So these are some of the use cases which AI can help in each stage. For example, target protein, which we can see. The literature can be searched by the AI and various other use cases. Okay, these are the data which AI go through, and these are the tools which is made by the AI. If you are finding it difficult to understand, just picture this. So all the literature, all the surveys, all the articles which are there for any treatment, it is getting stored digitally, and when it will come to research, so you need not to read every article, or the researchers need not to read every article, they just have to search in the database, and the AI model will be there to help them with finding the exact target and the exact lead which can help them to convert into a compound. Okay. So this is the difference in the traditional and AI-based approach in data collection, and this is one of the widely used tool, benevolent AI, which also helped in COVID for finding the alternatives. So in silico medicine, this is the first medicine which reached to the human with complete AI. It was done in 2023. No traditional approach was used. Entire thing was taken care of by artificial intelligence with the data set they have. Now, virtual drug screening is when you search all the compounds to find the lead of the target. So you have to go through millions of the compounds which are available to you, see how it gets reconstructed and all those things. So Atomwise has the tool called AtomNet, which they have used. So there was a study conducted where they used 318 protein targets, and they were able to find the compound, the lead for around 250, which is around 74% through the help of AI. And finally, the lead optimization where we fine tune the lead which we get so that it is safer for human. This can also be done with the help of AI. There are various tools which are available. Okay. Again, the data sources are high, it is good, efficiency is good, and also cost-wise it is very cheap. Then preclinical trial can be useful. The interrogative biology is one of the tools which is highly used in preclinical trials. So what they do, they take the samples of disease as well as non-disease, and they make a neural network with data, which has the characteristic of that particular disease, and they see whether the target is able to achieve this or not. So see the timeline, it has drastically improved, which was more than 6-7 years in initial traditional stage. It has drastically reduced with the help of AI. The repurposing. Anyone remember this from 2019? In COVID case, it was found that this particular drug can be used for treating the COVID patient. This was analyzed with the help of AI. This particular drug was being used for Ebola patient, and it was not very effective. With the tools which I had mentioned, it was found that this particular medicine can be used for treating the COVID patients. This is the summary of how we were able to detect with the help of AI with what tools. That's it. Thank you.
Thank you, Mr. I request Shashank to hand over a token now to
Hello, Miss Sumaya.
Friends, friends, it is my turn
to speak on liquid filled in and drip hard gelatin capsule for sustained release action. Now, before I speak, let me introduce myself to you. So basically, you don't know me, so let me introduce myself. Basically, each word used in this title is very important. So as I move forward, I will explain each of the lexicon used in making this title. My talk is going to be an interactive session. The person who answers that will get a sweet and crunchy part. Okay. So let's start first. Which science gives
deals with the study of does
to the body and what the body does to the drug.
who told me the answer first? Okay, come. Come receive the crunchy bar. I, you have not answered. You have answered. The study of adoption distribution. Okay, who gave the answer first? Huh?
Who gave the answer first? Okay, come.
Doctor prescribed
To take 3 tablets, either on full stomach or empty stomach. As the pharmacist, how would you advise the patient?
louder. I'm taking the ear plug out of. Yeah, tell me. Don't speak within yourself. Please be loud. Yeah, then you have to take 3 tablets in a day. And if this prescription goes to a nurse gives you a tablet, one in the morning, one in the afternoon, one in the night, right? Come on. Yes. And somebody said pharmacology, pharmacology, where is your pharmacology? And you are saying nurse is right. Nurse is giving you morning tablet, afternoon tablet, and night tablet to have a peaceful sleep for herself. Am I right here? Does it make sense?
That is speaking that you know pharmacology. Correct? Say yes or no. Huh? Anyway, when 3 tablets are prescribed to you to be taken on empty stomach or full stomach, you have to take at every 8-hourly interval. Why? Why every 8-hourly interval?
Is this correct?
Is this as per pharmacology? So the nurse giving you 3rd tablet after the dinner and going to sleep, or she goes to sleep thereafter. Are you going to maintain the drug level? No. The drug will be ineffective on you. Then you will blame the doctor for prescribing that medicine. See the vicious circle that is going on because of the wrong interpretation. Okay.
Which are the
Simplest and convenient and most economical drug formulation to be made. Huh? Okay. Any other ones? Any other formulation? I think liquid, clear liquid
Manufacturing is the simplest method of manufacturing, followed by simple capsules and followed by simple tablets. Correct? She disagrees. This is the right answer. Now, have you heard about a vegetarian capsule and non-vegetarian capsule? Huh? Yeah, tell me. Gelatin is what? And what is vegetarian? You got to be telling me vegetarian. Otherwise, no use of telling me non-vegetarian. Anyone? Okay. When I was in Saudi Arabia, there was a Saudi FDA inspection. And the inspection went through very well. The inspector, after the inspection, asked me, do you have a method to analyze quality of gelatin used in hard gelatin capsules? I was shocked. I had the method with me, or qualitative, not quantitative. But then I asked him, so why do you want that method? No, I heard pig gelatin is used in manufacturing hard gelatin capsule, which we don't want to recommend in Saudi Arabia. I said, what he says is correct. But if I give him a method, he will ban all the capsules prevailing in the market. Big, gelatin from pig. I said, sir, I think I have the method. I will try and search and give it to you. I did not give the method. But then I was thinking about it and why this fellow is asking for. Then I realized that classification, new classification exists in the market as vegetarian capsules and non-vegetarian capsules. So we'll get this answer. Liquid filled in antique hard gelatin capsule versus sustained release action. Each of the lexicon that is used in making this title has got a deep meaning, and you got to understand the right terminology for it. You got to know the exact definition of it. Then only you will make this formulation. What is liquid? Can I fill an aqueous liquid into the hard capsule? Please be interactive. Yes, no, what? Can I fill an aqueous phase into a hard capsule? Oh, good. No, you can't. It has to be non-aqueous phase. So we should be clear. When we talk about the liquid film, it is non-aqueous liquid, not aqueous. Non-aqueous liquid can be suspension, emulsion, or anything, as long as that liquid retains the liquid form till 70 degrees centigrade, and thereafter it can solidified or remain in unsolidified state. What is antric?
What is entering? Huh? So that means the formulation should not disintegrate in the stomach, but should disintegrate in the intestine. Am I right? Okay. So those formulations which has got an enteric coating or entering covering, that makes the formulation, it is enteric. Okay. What's hard capsule? Hard capsule. Hard capsule is a hard capsule other than a soft capsule. Right? Now, that hard capsule can be vegetarian hard capsule or a non-vegetarian hard capsule. That's a different point. But am I clear in hard capsule? What is hard capsule? But we'll see the actual definition later. Sustained release action. What is sustained release action? Yeah. Anyway, the release of the drug taking in the stomach or intestine on a prolonged basis, on a sustained basis, not immediately. So that's a sustained release formulation. Liquid, I'm talking about non-aqueous liquid, and any liquid that can remain as a liquid up to 70 degrees centigrade and it can solidify after that. So that's a non-liquid. Entry, what is entry? Hard capsule, sustained release action. So we have seen exact lexicon, all the lexicons that makes the title. But after we know what is what of the word used in the title, can anyone make the formulation, this formulation? As a pharmacist, experienced pharmacist? Yeah? So, to initiate the formulation, we got to know some of the terminologies, which are very important and crucial. This integration, any a capsule or a tablet is inefficient unless it disintegrates. You cannot expect a tablet to be taken orally. That tablet does not disintegrate either in the stomach or intestine, comes out of the anus straight away as a tablet. Will you get any action from that drug? So tablet or solid dosage form has to disintegrate. Okay? So how it disintegrates, what factors leads to disintegration faster or later? That plays a role in designing the formulation. Absorption of drug for systemic action. After disintegration, only the absorption will start. But absorption depends on factors like solubility of the drug, pH along the GI tract. Can anyone tell me what is the pH values prevailing along the GI tract? GIT? Yeah, quick, fast. What is the pH value in the mouth? Okay.
We'll move on to the next slide, and till then you search and you give me the answer. And take a crunching bar from me. First pass metabolism. This is very, very, very crucial to designing a formulation. Now, what is first pass metabolism? Yeah, someone said something. Huh? Yeah, that is there. But what exactly the liver does? Yeah, basically the input of your material greatly depends on what liver does to the drug. If it disintegrates, destroys, you want to take more dose. So you have to think of a formulation which does not allow the drug to be absorbed by the liver for systemic action. So that can be done by allowing the formulation to be disintegrated straight away into the intestine. Am I right? Yeah. Liver function test depends on liver function test, the formulation. Prodrug. This again needs to be understood very well. Why prodrug? And what are prodrugs? What are prodrugs? Yeah. I'll buy your definition 50%. Okay, anyway, for 51% also you take the crunch from me. Yeah, prodrug is basically an inactive or an active form, active form, which depends on how it works in the body. The drug, which is inactive by itself, gets activated because of the conversion it undergoes, and it either forms an active drug, absolutely inactive drug, or something like that. We'll see about the prodrug in the next slide. Now, this prodrug approach is adopted for those drugs which are sensitive to hydrolyzation or to oxidation or to any other thing which the drug at room temperature gets deteriorated. So you use an inactive form of the drug and then it gets activated inside. So like sodium ascorbate prodrug. But when taken goes into the stomach, it gets converted into ascorbic acid, which is an active form. We'll see about it later. First pass metabolism. Here what happens is the drug enters the stomach or the intestine. It is picked up by the portal vein. It goes to the liver. Liver does two things. One, sends directly the drug which is absorbed for systemic circulation into systemic circulation for action, or the drug in the liver gets undergoes chemical changes due to cytochrome P450 and conjugated enzymes. It undergoes changes into
metabolic transformation takes place, or that drug gets inactivated or gets activated. The three things takes place because of the first pass metabolism. We got to take care of this while designing the formulation. Now, today's topic basically revolves around historical background of the liquid filled entry hard capsule, risk benefits of using liquid hard capsules, filled hard capsule, classification of hard capsule, capsule shell preparations. Now, basically, in all of this, only liquid, the type of the liquid vehicle blend that I'm going to use, and the capsule cell preparation are two important things. Rest of the things, I can just even fast. The historical background is first the empty hard capsule, genetic capsule was actually designed in 1846 for pharmacists in the laboratory. And then later on, the capsule size was fixed in 1977. And thereafter, liquid filled hard capsule technology started. First, it was started by Merck in 19,000, then in 1950 by Pfizer, 1995 by Bristol Myers, and today there are so many other formulations available in the market. Now, what are the benefits of using liquid filled hard capsule? These are all the benefits. First, basically, you enjoy all the benefits of hard capsules, and all the other rest too are additional thing which you enjoy because it is a liquid filled hard capsule. Classification of the capsule. The capsules are classified into hard filled and liquid filled. Dry filled and liquid filled. Dry filled again classified into a hard capsule, hard gelatin capsule, and hard HPMC. HPMC is hydroxypropyl methyl cellulose, and that is the vegetarian capsule. Okay, so capsule formed with HPMC is vegetarian capsule. And capsule that is formed with gelatin is non-vegetarian. What is enteric hard capsules? Enteric hard capsules are two-piece cylindrical hard capsules made of either gelatin or HPMC. And we have also discussed what would be the content in the capsule, what could be the vehicle in that. So we'll skip to another. The market of HPMC is divided into two segments: pharmaceutical segment and the health and nutrition segment. Okay, I'll ask you to just recollect what is the pH value along the GI tract. Anyone? Anyone? I'll give you the figure. Can anyone tell me the pH value in the mouth? I want the pH value from mouth to anus. So unless you know the pH value prevailing along this track, you cannot think or design any formulation to get a desired effect.
Am I right, sir? Yeah. So these are the values. It is worth remembering these values. This plays a very important role in our day-to-day life. It will guide you even when you take a drug and you are hit up by acidity, and why you will know it immediately when you have taken the drug. Different steps involved in filling and sealing of the capsules. Separating capsule shell, that is separating body and the shell of the capsule. Filling the capsule body, cleaning capsule body, applying glue to the rim of the body, then placing the cap on body, inspection and packing. Now, if you really go through this picture, you think this is a very, very lengthy process. It sounds very lengthy, but there are machines available today that one side you dump the empty high-yielding capsule, the next side you get inspected and packed capsules out. It's all auto process. Now, having discussed the different factors and lexicons and terms, terminologies involved in designing a solid dosage form, we can think of this formulation, fabrication of entry capsule shell. Basically, if I give this formulation to my colleague Shashank Tarkar, he may come out with a new hard capsule. Am I right? Correct, no? But this is the basic form. And I used F1 and F3 in my studies. Of course, I used all the formulation, all three, but I finalized on 1 and 3. That is for nifedipine and isomeprazole present. Move on to the next slide. The composition of the liquid filled in capsule in general. Again, this slide, if I give it to my friend Shashank, he will come out with yet another liquid form to fill in the capsule and come out with a new innovative liquid hard-related capsule. So simple. You know, it just, when I utter the names with 2, 3, or 7-fold lexicons, you find this, this is a complex formulation. Or this complication, or this formulation does not exist at all in the market. This is the thing. But believe me, friends, if you know the terminologies that we discussed, if you know the definition of the lexicons that I used earlier or discussed earlier, liquid, filled, hard, gelatin, capsule making is a child's play. Okay? In my formulation, this PEG 400 plays a very important role. When the capsule reaches the heart intestine or crosses the duodenum, the disintegration of the capsule starts, and PEG having a good solubility with intestinal solid, it easily spreads that liquid throughout the intestinal fluid, and that forms a complex spongy mass and trapping the full drug in the capsule. And that spongy mass itself works
by releasing the drug at a slow, defined rate. So we get a sustained release action. Now, when I did my research, this capsules and these liquids, I had to do it myself. Various trials had to be done. But today, for you, if you are doing a research on this, anti-hard capsules are available in the market, which disintegrates at a defined pH or intended pH that you want. So one part you get ready-made. So the next part is you got to blend the liquid. To blend the liquid again, the basic formula is available for you. What you got to do, you got to be playing with this. Fix the composition for your own formulation and come out with a new formulation. Now, composition of a liquid vehicle for liquid filled anti-hard dilating capsule. Ingredient that's active drug. Then these are all the excipients. I use F1 and F3 to make my own formulation. Schematic presentation of the capsule. This is the different parts of the capsule, the cap and the body, and how it is locked, and how we got to be locking that. Now, liquid-filled articulating capsule, the basic difference between the conventional capsule and the liquid-filled articulating capsule for certain release action is the sealing part. For sealing of the cap and the body, you got to be spraying glue. You have to spray the glue around the body and then fix the cap. And then it becomes a permanent fix. For a conventional capsule, there is a locking system. You just press it and it gets automatically locked. But it can be reopened. This cannot be reopened. So it is foolproof. Now, what are the evaluation parameters for the liquid filled articulating capsule? There are only two important parameters. One is TT, conducting a TT, and second is conducting a dissolution test. If your formulation passes these two tests, then you are through for it. You are through in the market. These are again the pharmacogenomics requirement for TT and dissolution. These are various commercially available antric polymers. Ready-made antric hard capsule. All these are now ready-made, readily available. You got to just pick up at which pH you intend to get it disintegrated. These are again chemical studies conducted at the time of the capsule stage. These are ready-made capsules. Market products. Basically, this technology is used for PPI, that is proton pump inhibitors, anti-inflammatory drugs, pediatric and geriatric formulation, drugs with poor solubility, omega-3 fatty acid supplements, probiotic formulation, nutraceutical and dietary supplements. Future prospect. Antric capsule. Now, this technology is known that Quick Capsule Drug Delivery Technology, ECDTE. We get three types of ready-made capsules: PS dependent enteric polymers capsules, gel forming polymer for enteric coating, and the combination of one and two. Thank you, friends. If you have any question, you can ask me. Or if you have got the answer right now for the question that we already asked, you can take a keyboard. Yeah. So I think now we'll take a tea break. We'll enjoy our tea, and after 15 minutes thereafter, we will handle the most important, crucial, delicate part of our today's, that is price distribution. Sir, you have taken the basket. I'll check someone. Okay.
He's only going to do everything. So, correct, sir. Yeah. I'm going to remove this charger and put in my bag. What do you do now? You remove those trophies and put that here. That is below that.
अरे वा कुठलं कवर पण लागतं कसे लेन्स तुझी अडकळली काय बोलताय काय बाकी होत ना सर आवाज येत ना सर बंद करतात ना बघा जरा फोकस पाहता हो सो फोकस करू बेटा बस आहे बरोबर ना त्याने जे बघायला साडी दोन सांगा करू साडी दोन उडवून घेतात लॅपटॉप गरज ना सांगून तो नाही पाठी माझी पाठी आम्ही फाट्यातून बसलो
Hello. The first name is Felicia. Vijay, sit in the line, please. Sumaya, Jessica, Viti, Pratham, Naman, Akshata, Jyoti, Sanaya, Amisha, Nisarga, Sheetal, Bhagyasri, Akshata, Simran, NCT, being alive. As I call the name, you will have to take the certificate.
Hello. We are coming to a closing ceremony of what today is doing.
and our chief guest, Mr. Maman and Nitesh Naik are already here. But before I take them to the dais, I would like to show them what is our group about. I'll just have detailed.
Before we take
Hello. Before we take dignitaries on the stage, I would like to introduce our distinguished guest for today's occasion, Mr. Alumni. He is proprietor of Nice Pharmaceutical. Uh, and I will make a presentation about him to know his profile and details. Now I request Vaikun Kamat, to give up and take them to the dais and occupy yourself.
I request Sheetal Sundar Pandit
To hand over the floor to Principal Dr. S.N. Mohammed and Program Coordinator Suvarna Mogli, Dr. Suvarna Mogli. Our group has decided to give of 1 dozen full-scale notebooks to 6 students of PES college. The 6 students are selected by principal of the college and program coordinator as per our request. I call upon I call the names of the 6 students to please come forward and collect your notebooks for the gift. 1 minute. I request our classmate Kazi Imtiaz, Vishwambar Sawan, and Shashank Thakur to come closer to me and hand over the gifts to the 6 deserving students. Okay. Milind Lal, please come forward. I'll call out the names of 6 students. Please come forward and receive their deserving gifts. Mr. Narayan Bhosle, MS Kirti Markaikar, MS Upasna Shankar Kumbar, MS Amisha Surekant Mandrekar, MS Komal Lokman Udekar, MS Deepti Pal. Now each of one of you just come here and collect the gift from our classmate. Thank you, Kazi. Thank you, ma'am. Thank you, Shikha. It is always an occasion that for any gathering, seminar, or for any occasion, you always call chief guest or some other title you will give them. They see our function and they are bound to give their observation also and give their viewpoints. So, in that context, I request our principal, Dr. S.N. Mamle Desai, to say a few words on this occasion.
Good evening, all. Somewhere in June this year, I got a phone call from our secretary, Mr. Ritesh Naik, saying that Sri Uday Barat has some plans to organize some seminars and invited lectures, and we coordinate with him. So I and Madam Suvarna Bhopte, we had a discussion with Dr. Uday Borat. So so that the things moved, then the things moved. So we have to appreciate this man Uday Borat. So for his meticulous planning and follow. So somewhere in June and July we met, and immediately the things started. Okay, immediately the things started, and his meticulous planning and his follow, and the way every point he used to discuss with us and how to do this, and every next day used to come with the result. Okay, used to come with the so these are the ingredients, so these are the program details, so these are the program details, and who are the many the students whom to invite. That also he had thought of it. That also he had thought of it, and he traveled also twice. He traveled to the places where the journey is not that comfortable. To travel to Belgaum and to travel to Hubli and Dharwad. It is not that easy. Every day we read it in the newspaper. Every day we read it in the newspaper. It is not a comfortable journey. He traveled twice to Belgaum and twice to Hubli to meet the principals of those colleges. Those who are here, Rani Chennamma College of Pharmacy at Bauxite Road, Belgaum, or my alma mater, that is Kelly College of Pharmacy, Belgaum, at Nehru Nagar, and Maratha Mandal College of Pharmacy at again at Nehru Nagar, and my previous college at Kelly College of Pharmacy, Hubli. He met twice and he invited the students from those colleges. So today in the morning, we witnessed the whole day how they celebrated the seminar. So I appreciate each one of them, and also the students from Goa College of Pharmacy and as well as our own students, and gave a very valuable, very beautiful seminars in the morning session. I congratulate each one of you. Some of you might have won, some of you may not have won the prizes, but overall it was a very satisfactory seminars for me at least. Regarding the Uday Bharat only. So let us give a big applause for him. It's such a very good. And he's a multiple. When we came to know, when we met several times, what type of man he is. Okay, he's a multifaceted man. So looking at his experience, looking at his experience, he has a vast experience in the pharma. And he has written so many books, and all are well-known publishers. So all are well-known publishers, and those publishers he has given to us. And above all, he's a very good chef. He is a very good chef. So that is no one might think, only those who are his classmates, they might be knowing him. So meeting him quite frequently, we came to know his multifaceted personality. So he's a great person. Okay, along with the Sri Vaikunth Thomas Secretary, has traveled all the way. Several times he traveled to our college and to check out the things. Sir, it is a great effort from you also, sir. And Madam Sheetal Pandit also, she's a President Woman Representative of the 1970. So you have a wonderful batch with sir. Congratulations to all of you. Have a great time still, 1979 batch. You have a wonderful team, sir. Have a great time ahead also. And at the very outset, I want to thank our chairman, sir, Sri Ravi Naik, sir, because of his visionary effort to infrastructure, which has been appreciated to everyone, which has been including our Arun Baba Naik, sir. He appreciated everyone who have come here. Our special thanks to Ravi Naik, sir, who is a Minister for Agriculture and Civil Supplies. So because of his visionary effort, this all are possible. In the audience, we have Salil Kare, sir, who is always supportive for us, always has been supportive for us. Sunset Farmer, I welcome you also, sir. So in the audience, we have all the judges who are there in the morning. They have done a great job, sir. So with these few words, I hand over the mic to our Bharat, sir. Thank you.
Thank you very much, I want to recognize officially presence of Mr. Salil Kare, who has come all the way from Margam
on our and attended our function on our request. I want to introduce Mr. Salil Kare. Mr. Salil Kare is B.Pharm, passed out B.Pharm from Goa College of Pharmacy. He did his M.Pharm in Goa College of Pharmacy and MS in US. He is basically a proprietor of Sunset Pharma distribution firm and Sunset Pharmacies. Pharmacy and pharmacy-related business is Karen's family business. He has taken it to a new height. I called him specially to inculcate some spirit in you so that you don't run only after job but be an entrepreneur. Be like him, and that should be your vision. Thank you, Salil, for having me. Secretary Sri Ravi Naik, Anka Mr. Mulova, Puchapuri. I would like to say something, express myself. So, we are very thankful to your father, Mr. Ravi Naik, and also to you for allowing us to conduct this function in this premises. Having received a go-ahead, I contacted Principal Mamli Desai, Dr. Mamli Desai, program coordinators who are now away, and they extended full support to me. Even my visits, which Dr. Mamli Desai has spoken about, my visits to Belgaum colleges and Hooghly colleges were actually inspiration I received from Dr. Mamli. And that's how I could establish my contact with 4 colleges from Karnataka. We will, from next year, we will try to include closer cities from Maharashtra in our function. And that's our vision. Because of this full support that we have received from this college, I would like to make an announcement that henceforth, our connect will be in this college. And we expect more support from Ravi and Ritesh for conducting this occasion. We will get the student from Maharashtra colleges also here, and will celebrate our Connect 2K25 next year in this college. That's our vision. I request Mr. Ritesh to say a few words on it.
Good evening. Of Connect 2K24 seminar and presentation competition organized by 1979 classmate group of GCP in collaboration with PS Rajaram and Taliban, Bandira College of Pharmacy. We have on stage Mr. Arun Baba Naik, owner and managing director, Merit Pharmaceuticals. Mr. Vaikunth Kamath, President of 1979 Classmates Group of GCP. Mrs. Sheetal Pandit, Woman Representative, 1979 Classmates Group of GCP. We have Professor Dr. Ahmed Desai Sir, Dr. Suvarna Bhagna, Assistant Professor and Coordinator. Mrs. Salil Kare from Sunset Pharmacy, judges. management committee members of GC 1979 classmates group of GCP who have come here, and all the students who have come from different colleges from Goa and also out of Goa. I think we are very happy as a society. We are, as a management, I'm here, and we are very happy that 1979 the GCP classmate group have organized such an event. I think this is going to benefit students, and seminars and talks given by guest speakers. We have seen, we had virtual talks from Boston, USA also, and various talks by Pradnya Palagurkar, Shreyas Kalagurkar, then Dr. Bharat also. Uday Bharat also spoke, and Tarun Lakmani from IIB. I think it's a wonderful opportunity for students to expect showcase their talent and research. I think you are going to you have researched and come here and you have given a wonderful presentation. Which I came to in the afternoon. That session was wonderful and the presentation given by students were excellent. All of students have, I think, more than I think at least 80 students participated in this competition. I think this is going to be help you in your future academic career. And I think, first of all, I want to compliment and appreciate the efforts by Dr. Bharat and all his, and Dr. Mr. Vaikul Kamat and all his team members, Mr. Sheetal Pandit and all the management committee members. Because, and you know, reunion we always have, but this is something different type of reunion where they organize this function and these students are going to get benefited from this. And the speakers were excellent. I think the speakers, with the topics which were selected were excellent. I think this is 100% going to help you all. And also I want to share that our college also this year has given approval by Goa University as PhD center. And this also I think will benefit Goa students. And from out of Goa, I think there are many colleges which have come. Rani Channamma, I just want to make a reference. Rani Channamma College, Belgaum, KLE, Hubli, Belgaum, Maratha College of Pharmacy. I think I would like to welcome, on behalf of Kota Education Society, I would like to welcome you all for this function. Welcome since the morning you are here. And we are very happy to organize it. We are collaborating with GCP 1979 batch. And this is going to be a long way. Dr. Uday Bharat already said that next year we are going to have it here again. And we will be happy to organize such events which are going to benefit them. So once again, I have to congratulate all the students who have participated and those who have been will get awards. Again, I would like to say the best of luck for all your future. And also, as Dr. Bharat has said, that Salil Kale has become, he studied abroad, but he came here and started his career as an entrepreneur. So, look at that aspect also, and wish you all the best. Thank you.
Thank you, Krishna. Before I ask Mr. Arun Mama Naik to say a few words, I would like to say that when he starts his talks, he always comes out with all his past memories and all that he did for pharmacy college students, and to pharmaceutical manufacturing world. He is chemical engineer by profession from VGTI college, most famous college during those times and till today it is famous. I hope he shares some of his experience related to managing the affairs of Goa College of Pharmacy as appointed person by government of Goa. And
also share in your college thoughts which will enlighten or give inspiration to this budding pharmacist. I call upon Baba Naik to say.
Thank you, Uday, for a flowery introduction of mine. Wish I could reciprocate by giving a good talk. I don't know, I'm not sure, because I don't think I know the type of introduction which Uday has given. Anyway, first and foremost, I would like to congratulate Dr. Uday. This has nothing to do with the flowery talk she gave in my favor. Because I have seen so many reunions, including our reunion. Whenever I go to Bombay, I just phone a couple of friends and ask them to make a reunion. That is only a party. I have understood that every reunion results in only a party. But this is the only reunion which I have seen, which is knowledge sharing. I haven't seen it anywhere. It's really thoughtful on the part of Dr. Uday Baran to conduct this type of reunion. And the type of enthusiasm, he told me about this about 7-8 months back. And that was not by a phone call. He came to Penji. Arun, I would like to meet you. I said, okay, I don't mind. I have to come all the way from Madgaon. No, I will discuss it. And this was only to say that I will be invited for this. And since then, started meticulous planning. That is so wonderful. I have never seen this type of thing. And from the response he is getting here, I can say that he is very successful in this and wish him all the best in all the future. Now, I want to compliment Mr. Ritesh Naik, the secretary of this college, and his father, Mr. Ravi Naik, the chairman of this college, for having started a pharmacy college. Most of the people in Goa would either start a arts and science college or a commerce college or engineering college. They were the first to start a pharmacy college. Of course, they took advantage of that. It really reflects on their thinking beyond time. Because pharmacy college, who will come for pharmacy college here? How this Goa College of Pharmacy is doing? Nobody knows about all these things. And despite that, they persisted and they started really thoughtful on the part. Even if I had that kind of money and power, I would have started some engineering course. Not a pharmacy. But it is very relevant now with the pharma industry growing in Goa like anything and all over India. It is very relevant that they started this one. And just the other day, about exactly 15 days back on a Friday, not last Friday, but last week was there, I had an occasion to interact with the pharma industry of Goa. And there was something called Goa Pharma Expo or something like that in a hotel here nearby in the bay. And there the representatives of pharma companies, including their plant heads and all, had come. And there I got an interaction which showed that the pharma industry of the old times is totally gone. And now people are talking about AI, artificial intelligence and all this in manufacturing, in design, and everything. So we have to be prepared for that. Now, regarding my experiences in Goa College of Pharmacy, somewhere in 2002, it was pure accident that I got involved in Goa College of Pharmacy. Because I was a pharma manufacturer right from 1977, and I used to go to Goa College of Pharmacy mainly to accept library books. Because that time there was no internet, nothing, and only library books were, and they were giving us a free hand to read any book there. That was the only content. And once in a year, IPA function. And that IPA function was mainly to say, hello doctor, how are you? To Dr. Fleers, the drug controller then, to show our presence and then just keep quiet like that. That was the IPA function then. Let me be very frank about what was happening in IPA then. I don't know what is happening now. Then, in 2002, a friend of mine who was on Goa Chamber of Commerce committee or something, he phoned me, Arun, I pharmacy college में कुछ program, not in pharmacy college, that was held in Goa Chamber of Commerce, Goa Chamber of Commerce, all in Penji. I cannot attend it, please go on my behalf. There, I don't know, the Secretary of Education was there, and one Dr. Ajit Chorota, who most of you will be familiar with. He was there, and there was Goa College of Pharmacy was in problem. That is what I understood there after having attended the meeting there. And then we came to the conclusion, well, I was sitting on the dais along with other two or three people, along with the secretary, who was a big man, genuinely a good person, Secretary of Education in charge of pharmacy college. And then we, after about calibration, shouting, no, you are this thing, you are this thing, all this thing. After about 1 hour, we came to a committee should be formed. And they told me to form the committee. So I formed the committee in which I was not there. Because the principle is, if I am there and I include myself in the committee, so how it can be said that it is selected committee? It's not like that. So then they said, no, why you are excluded? I said, how can I be in the committee in which I select the committee? It should not be, there should be some principles inside. Later, it started. After about 1 month or so, I got a phone call from Raj Vaidya. You know, Hindu pharmacy, everybody is aware of that Hindu pharmacy. Sir, I will make you the chairman. I said, chairman, me? I don't know anything, ABC of pharmacy. Why you are worried? I will give you the entire chairman. And he made me the chairman, along with other members, of which principal of our College of Pharmacy was there. Secretary, not secretary, the director of technical education, and other senior staff members, and 2 or 3 from the industry and distribution and all. And that is how we started learning about pharmacy college. At least me, there were a lot of problems. The problems were mainly because it was a government college. In government, it is very easy to criticize. Minister, it has nothing to do with the minister. Let me be very frank about it. It had something to do with the secretaries, whom we called babus or the bureaucrats or whatever. And the secretary is the least concerned. Because what used to happen, the pharmacy college principal cannot go to the secretary and tell him, sir, we want this, we want this. He will just say, shut up. Because it is like this, no hierarchy is there. The pharmacy college principal, being of a government college, is always under the secretary. He would not say. Whereas we started telling him. One of the secretaries told me, you are, I think, exceeding your powers. I said, what are our powers? No, your power are only guidelines and all that. You can't interfere in that. Okay, I said, we are going and resigning. But immediately after that, we are calling the press. The moment I said press, the secretary said, no, you don't resign. Right? Why this thing should happen? This is a fact. And then this gave power to us. But the chief secretary then, one Mr. JTC, was very cooperative and very helpful to us. He had told me, if there is any problem, just walk into my cabin. And I used to do that, and people used to walk like commoner and just looking into the chief secretary cabin. It had to do only with the pharmacy college, no personal thing, nothing. It included complaints about the teachers also, which we used to get from the students. So these are all the things. Then there were around, out of the some 25 or 30 staff, there were 15 or 16 vacancies which have been lying for the last 3 years before we took over. Despite that, they were continuing in the education. I don't know who was teaching, who was getting educated and what not. So we hired the director of technical education. Why are you not filling the post? They said GPSC chairman is not releasing the advertisement. We went to the GPSC chairman. Baba, what is holding you from it? No, we have a quota. We can release only 2 advertisements of pharmacy college, 1 of engineering college, and like that, whatever. I said, no, this is very important. Then he obliged us by releasing the advertisement. And soon, these vacancies started filling in. And later on, the college started coming online. So it had nothing to do with me as such, because there were a lot of gaps which were to be filled. And anybody could have done it. Any person on the street could have done it, right? Just somebody should have had interest. Anyway, now let us come into this. At that time, this College of Pharmacy had started, I think. We started somewhere in 2007-8. Yeah. And that time, since I was the chairman of Management Council, I always looked at Goa College of Pharmacy as my college.
I know I was having tussles with Shilpa here. She will say, no, our college is better. I said, no, my college is better. And somebody told me, Arun, तुझे college टेक्नाचंद झालं. No, I am the chairman of the management council. I think this college belongs to me. Belongs to me in that sense, nothing else. I remember having tussles with Shilpa. Do you remember Shilpa? And she was very adamant, no, our college is good and all. And later on, I saw Mangirish, then Paul, all from Goa College of Pharmacy joining here. So I said, this is like politics. You know, it is only the hotels who fight, the politicians are white. So it is either Goa College of Pharmacy or ES College. But now ES College is doing wonders. You go by the report, the number of PhD which are coming out every year. It's not a joke. In fact, in Goa College of Pharmacy, PhD started recently, I think in the last 10 years or so, or maybe last 7-8 years. And then too, I put some of the people, because there was a general complaint. If you are not PhD, you cannot occupy the principal's post, because that was the minimum qualification which was given. And most of the teachers who were there were my classmates in Depe College in first year and Intranasal. I had to fight with them because it was a matter of principle. Because the fight was not carried out after the meeting was over. But there were strong arguments. Why, Mr. Pai, what are you doing? What is this? Why are you not doing? No, this is not happening. You won't understand this and all. Very heavy arguments and all that. Of course, it was restricted only to the meetings and all. So now, students, I'm very happy to see you here in good strength because this pharmacy course offers a lot of opportunities. If you go by how the industry is doing in Goa as well as all over India, you can do wonders. Of course, there are a lot of fields which you will have to make a choice. You can go for manufacturing, or you can go for drug administration, or you can go for academia, or you can go for research. There are so many avenues which were not there, I tell you, when somewhere in 1977, 78, this Carter will Mr. Kanta, people from Goa, who were possible from Goa College of Pharmacy used to go to Bombay because there were no companies here except probably CMM and this Salil's Kari, PCI Pharmaceuticals. Only two companies. Third was my Merit Pharmaceutical. But there was not much employment. Most of the employment was in Bombay. Now there are a lot of companies here. I'm told there are around 80 units. Most of them are US FDA approved, MHRA approved, because they are exporting drugs to US and other developed countries. And they are one of the finest setups they have got. And almost about 80% of their production is being exported. And Goa still contributes about 8 to 10% of all Indian production of drugs. Maybe it has come down to 8%. Initially it was 10% because now facilities were given by other states and many companies rushed there. So because of that, Goa's production hasn't come down, but as a percentage it has come down. So it is about 8% of the total produce of pharmaceuticals in India. So to take advantage of that, I urge the students, do not stop at B Farm, please. Because I repent. When I was doing my final year and I was about to appear for the last paper, I had decided, you could have put the word from, I'm not going to study further. I got so much better. Because I was staying in Bombay in a hostel, I was, a little food conscious. I wanted to earn food, home food. I said, no, nothing to eat. I was sure I will pass final year. Once I passed, I said, no, I'm not going to. But now I repent. I really, not now. After about 10 years of working and all that, I really repent. And this is not like the US. In US, even married people go and join this. This is what I am told. Then a friend told me, why married people go and join a cohort? Because instead of listening to lectures from the wife, they prefer to listen lectures from the class. I don't know how far it is true. But on a serious note, I urge all the students present here, please do not not stop at B Farm. Once you do B Farm, you may work somewhere for about a year or two, because after working you come to know what you do not know, what is lacking, because there is a lot of gap between the industry and the academia. In academia, you learn a lot of things, more than what the industry requires, but it is exactly not fitting with what are the requirements of the industry. There is always a gap. So once you join an industry for 1 or 2 years or 3 years, and come back for any farm. And if possible, do PhD also. This is my strong advice to all the students. Because you will also get fed up. The way I got fed up in 1973, I remember that day, somewhere in April, when I was answering my last paper. No, nothing of examination. This is the last examination I am going to do. If I can do that, why not? I'm telling myself, hello. So, as far as possible, try to continue with your education, either from B.Pharm to directly to M.Pharm, or by going for a job. Then don't go for a job just because you get a job. Wherever there is a liking, you go for that job. There are different types of jobs. Production job and a quality control job are different. And don't just go for a job because it is available nearby. I met a student, a pass out from this institute, who is working in Zydus. I said, from which college you are? I am from PS college. I passed last year or something. And he has joined Zydus. Why did you join Zydus? And it is there. He is from Kolkata. So Zydus is at it is nearby. I said, Berna is far off. Berna, कोई सा काम है, वो बच्चा जो पाक खाना खड़ा है. And he is a young man of 24, 25 or whatever it takes. What is this? I was shocked. And he was complaining, these non-governors are not treating us properly. I said, nothing to you. I'm not going to listen to all these things. I know there is a disparity. Suppose tomorrow I go to Uttar Pradesh and there I am asked to hire certain people. I definitely give priority to my local governors. There's nothing wrong in that. Some priority will be given because I am familiar with them. I can trust them or whatever. Same thing is happening here. Don't think that everybody is against you. Let that feeling be not there. Because if you perform, there will be times that the company will say, whether you are Goan or non-Goan, it doesn't matter, you stay. It is like that. You should make yourself inaccessible, sort of that. And then, about a few years back, when I was still in the pharmacy college chairmanship, a girl approached me, sir, if you can do, my sister is there and she wants a job. I said, what she has done? She has done M.Pharm. Okay, you send her this thing, I said, and there was a company called Blue Cross. So I had a friend in it, the boss was there, my friend. So I said, you go there, this is an interview. And after 2 days, she came back. And she went, I asked her, and she was, trying to hide from me. So I asked her, what happened? No, they didn't give me the job. I directly picked up the phone and asked people there, what happened? She wants only quality assurance job. Right from first day, I understand quality assurance is given to those people who have got experience either in production or in quality control or in both. Because you know the hurdles of both the departments. Then only you can go. It is just like asking somebody, I want a police job, but give me the police chief job. It is like that. What you are demanding? Then another fellow was there. He said, I want a job, sir. Okay, I will try. He said, I'll ask the college people whether there are some vacancies somewhere. And he said, no, I want it only in Mapsa. What is this? And this is the mentality of all cohorts. Isn't it? Then I think we should get out of this. We should also tell our parents how to get out of this. And coming of the parents, it reminds me of one thing. In Goa College of Pharmacy itself, we had one meeting on a Sunday, so that parents should come. And interaction. And those parents were those who were, they were the parents of the students who were appearing for the final year. So what are your expectations? We asked. Myself and other people were there on the dais. They said, IT people are getting a very good salary of 30,000, 40,000. Those days, 30,000, 40,000 was a very big thing. Not not like today, 30, 40,000 is nothing. This is what I'm talking about 10, 15 years back. And pharmacy college students are getting barely 10,000. I said, okay. IT students, after this thing, 2 or 3 years, they may be even sacked or they may be asked to go in a different department. And then they prove themselves. Whereas in pharmacies, in pharmaceutical industry, you will grow up and grow up and grow up. Fortunately, the person sitting next to me was Mr. Sanjay, this Priorkar. He said he was getting a salary of 300 rupees per month, and I am drawing a salary of 2 lakhs per month. Then, as the plant head, I said, this is the example. So if you are ready, you can't expect the highest salary in the which industry. I think you will have better examples. See, Mr. Vaikul Kamar, who I understand from the biodata given, he started as a medical representative somewhere in 1980 or something. Now he is the owner of a company, which is a well-known company. So this is an example in front of you. So please, keep all these things in mind when you decide about this thing. Now, even when Dr. Barad was presenting his lecture just before this session began, I came here at around 4:10. Dr. Barad was presenting a lecture. He asked certain questions. I immediately opened my WhatsApp and I asked Meta, what are the different levels of pH in the digestive tract of human body? Because he was asking me regarding that capsules and he gave me a very total detailed reply, which I don't remember now. It varies from 2 in the stomach, 3 in the thing, and 7 and all. So when all this data is available at the click of not even a mouse now, at the click of your just press of your finger, why not use it for better purposes? Not just send WhatsApp messages, which is no money. Hi, how are you? Everybody is fine. Good morning, good night. Forget about these messages. Try to gain something out of the mobile, which is in your hand. Of course, you can use it for those messages also, purely as a time pass, not as the main thing. Whereas this information you can get, I don't know whether it is AI or whether it is Google, but it calls itself AI, but it gives all the information about anything. In fact, I tried to find out information about this college also. Then they said there is one more college called PES in Bangalore. I said, no, I want the one they give me all those things like that. So you be very careful about using AI also, because I had a very bad experience. The first time I came across AI was about a month back. There was my experience with AI, I'll tell you, about a month back, that is the first time I encountered AI. On Facebook, there was some video. आजकल तेरे मेरे प्यार के चर्चे है जवान पर where Shakti Kapoor is dancing in cars and looking like this. You remember that movie? What is that? Brahmachari. And I just liked it. Liked it, press the button like. And then put a comment. Oh, beautiful movie. I remember having seen it in Chennai National in 1968 in Pandi when I was studying computer science and all. Then they asked me, you want to know more about Shankar Jayakishan songs? Yes, yes. And then he said, one song, first song was from Mere Sanam. I registered. Mere Sanam, the music was not given by Shankar Jayakishan, it was given by O.P. Nair. Oh, very, very sorry. So be careful about AI. Don't think that whatever AI gives is correct also. You can test your knowledge with AI. You can test AI knowledge with you also. It is also possible. But make the best use of all these things for your curriculum. Okay. Thank you, Dr. Bharat, for giving me the opportunity.
Thank you, Mr. Arun. I think
Today,
We have come to a concluding part. The last session being on my agenda, handing over the prizes to the winners and handing over the rolling trophy to the college team. I have the results with me. The declaration of the winners I'm going to announce the winners. Before I announce the name of the winners, I thank three judges, Ashok Pai, Manor Gandar, Blanche, Rosario, for being the judges to judge the presentation by pharmacy college students. The second runner-up prize goes to Mr. Kirti Madkaikar of PES. I request her to come forward and receive the prize from Sheetal Kamat Pandit. First runner-up prize goes to MS Nisarg Sindhi of RCC body, that is Rani Children. I request to collect this prize from Dr. S.M. Mandela sir. Okay, I'm sorry. Any guesses on who would be the winner for today? Any guesses? Any guesses? Okay, I'll announce the name. The winner of today's presentation competition is MS Shania. Yeah, he will receive the prizes from Mr. Arun Baba. One minute. Let's give you some receipt that prize. There's only one rolling trophy remaining there on the table. Now, can you guess which college gets this? Now you know the winner, the second runner-up, first runner-up, or everything you know. Who should be getting the rolling trophy? Any guesses? Okay, anyone? Since no one is telling any other name, I would like to declare that I concur with my brother, rolling trophy goes to Rani Chennamma for all three members please come and receive the rolling trophy at the hands of retail students. One each. Of the trophy, that is first prize, second prize, and third prize. I have a wooden case. You'll have to get it back. I'll help you out so that it will help you to take it from college to your residence. Let's say. Okay. Now we want to hand over a token of love from us to Mr. Ritesh Naik. I request Vaikunth Kamath to hand over the token of love to Mr. Ritesh. I request Sheetal Kamath Pandit to give a token of love to Principal Dr. S. M. Mohammed, sir. I request Vaikunt now to hand over the token of love with program Dr. Superbugs. Request Vaikunt Kamat to say give a vote of thanks. Yeah, friends, certificate of participant to all the participating members. You will get your certificate today late evening or will post it to your college. Okay.
हांव आज तुमच्या सगळ्यांचे आभार प्रकट करपाक लागून थोड्या लोकांक कोंकणी कळटली कळची ना समजून घ्या. सगळ्यांत पयलीं हांव आमचे मानाधीक चेअरमॅन रवी नायक हांचे बद्दल चड उलोवपा सारकें कांय ना. एवरीबडी नोज हिम गोवा. He was the ex-chief minister and he has been MLA several times. So, but as a resident of this college, I thank him very much for having given us an opportunity to conduct this event in this college. So also, I thank Mr. Ritesh Naik, Secretary of US College, for having given us an opportunity to conduct this event. It is sometimes it is very rare. You know, when usually somebody approaches for any event, पयलीं म्हणटा राव म्हणटा विचार करून मागीर तुका सांगता. पूण रवी बाबा आनी रितेश बाबा at the first instance आमकां भंय पडली आनी ह्या भंय म्हणपा फाटल्यान आमचे प्रिंसिपल मामलेदार प्रिंसिपल आणि कोऑर्डिनेटर हांणी जे आमकां हेल्प केला. It was because of that at the first instance they said yes for organizing this event in this college. So I thank them also very much. I profusely thank them. I also thank speakers, Shreya Karmakar, Shreyas Karmakar, Pradnya Karmakar, Mr. Tarun, Mrs. Yutika Sisat. I thank them for their contributions. I also want to thank principals of all the 6 colleges who encourage their students to come out here and be a part of this event. Guru Baba Naikacha, thank म्हणटा ताणी वेळ काढून हांगा उपस्थित रावले आनी तांणी आमचे विचार मांडले. आमचे स्पेशल गेस्ट पोस्ट ग्रॅज्युएट स्टुडंट्स ऑफ फार्मसी कॉलेज हांचे हांव सगळ्यांचे आभार मानता. पार्टिसिपंट्स, व्हॉलंटियर्स इतले आशिल्ले की दॅट एवरी स्टेज प्लेयर व्हॉलंटियर्स, गिफ्ट हाडपाक व्हॉलंटियर्स, बुके हाडपाक व्हॉलंटियर्स, मायक पळोवपाक व्हॉलंटियर्स, फोटो काडपाक व्हॉलंटियर्स. I have not seen such type of cooperation from any state. So I thank all the volunteers very profusely. Staff members who coordinated with us, caterers, आज जेवणही बरें आशिल्लें, अडचण्याचे तोंडाक एकदम सुंदर घालले. So I thank the caterers also. everyone played a very crucial role. So whoever has helped us in doing this event, I thank all of them. So with that, I would say that this was a very cherished moment and very present day that we had. I love you all, boss. We shall meet soon once again. Thank you.
Friends, officially the function is over, but we are going to have a photo session. I request Mr. Salil Kare and all the staff of the colleges, please come on the stage. We'll have a joint photograph. Okay? And then we want participants, the volunteers to come on the stage and have a photograph with us. Okay? We want to include your photo on the brochure that is going to be. Mr. Salil Kare, please. After this photo,